because it is taken peripherally. So you block the peripheral use to make it more available to central nervous system. And this is used in different combinations, cyanamide or in many drugs. So you know, dopamine, when it is used, it is split by monoamine oxidase inhibitor. So if you give something which is monoamine oxidase inhibitor, we will also make it more available. The danger of these medications is if you use indirect catecholamines, they cause hypertensive crisis. Okay, so you be careful about them. Even any material that contains even tyramine, it will cause hypertensive crisis. COMT inhibitors, catechol or methyltransferase, is the enzyme that destroys dopamine. So if you give a blocking agent for this enzyme, you will make it more available. And now this is given also in combinations. The most famous of them is Stalevo. I will go directly to the most recent development about stem cell in Parkinson's disease. Now, one of the successes in Parkinson's disease is to use hematological stem cells, and they are put into the substantia nigra. What happens? They start to differentiate as dopamine-producing cells. And there are quite successful centers in the world, including Mayo Clinic and Cleveland, Ohio, and now even in King Faisal Specialist Hospital in Riyadh, they do it. But it's not readily available for the public. It is still in the early experimental stages. And the use of the pyramidal system led to the discovery that if you give simultaneous stimulation to a patient, this will help them to move more. This gentleman, I applied auditory cueing. When you tap, for example, ask him to count, from freezing he will start to walk. Once you stop doing this, you see he walked. He's not taking medication. 4 hours after the dose. This actually confirmed in a big study in Oxford University and Newcastle. If you see this patient, now he is asked to walk, so this is using the extrapyramidal system alone. You can find this in the website of Nature Neurology. But the idea is, once they put cueing for him, he started to walk almost normally. So you can combine, can reduce the doses. Some patients even might not need, if they can do a lot of cueing in themselves. أنا هذا العلاج بتسبح سبحان الله سبحان الله وامشي أو أمشي زي العسكري. So this gentleman walked almost normal. I'm sorry, I'm not working from my laptop. I'm a bit awkward. I'm a bit awkward today. Type. Apomorphine is used for difficult patients. It is given by a pump subcutaneously. آخر ما في التقليعة. This deep brain stimulation now is well established, and actually Dr. Spielman in Amsterdam, he started doing, now it's available also in Jordan, available in Cairo, available in Saudi Arabia. The idea is, both substantia nigra, it has a very slight reserve. If you give stimulation, you will stop the inhibitory factors. You are not giving dopamine, you are stopping the inhibitory factors for dopamine. So you are not giving new, but you are stopping the inhibitors. This helps the patients reduce the amount of anti-Parkinsonian drugs. Some patients might not need any treatment, but you must tell the patient once they go for deep brain stimulation that it is not replacement for medication. Many people think that أنا أمشي أعمل عملية وأوقف الحبوب. لا، يعمل عملية ويقلل نسبة الحبوب. I trained with this Spielman in 2005 in Amsterdam. It helps with mobility and it helps with feeding, but there is no impossibility under the sun. This patient became immobile with a neurological disease. He don't have a Parkinson's disease, لكن أنا بقول إنه حتى في الريف السوداني you can always make modifications to help patients mobile. ما عندنا كهرباء، ما عندنا طرق مسفلتة، لكن بنطلع له الحمار في الويل شير وصار تعرف وفتح كشك بدي يبيع رصيد وحسب ما شاء الله he is doing so well this one. التراديشنال ميديسن يا جماعة برضه ما تحملوا. في ناس كثيرين are experimenting with this, but I will not bother you, including Gum Arabic or Full Sudan, education about Parkinson's disease والديفلوبمنتس كلها الدراكس كثيره. دي المره اللي عملوا لها اكسبيرمنت انه قالت هي لما تركب على الباص بتشم البيشنت عندهم باركنسونز ديزيز. قام دكتور في بيرمنغهام عمل اكسبيرمنت بيت سكان طبعا اخذ ام ار سي جراند وجرب في بيشنس شمت العيانين ديل كل العيانين شمت طلعوا بوزيتيف في البيت سكان some of them were not even clinical having Parkinson's disease and this is published work. شفت عملوا ماس سبيكت ستدي لناس كثيرين اللي ناس ما جابوا نورمال سبيكت والناس اللي شمتهم المرض دي طلعوا ايه؟ This is published. So this ultimate test now you can شفت الكلام ده كده؟ فشي said nobody believed her but that doctor believed her and he proved it. Because of shortage of time, we'll not also go on this. Angiogenesis for cure of Parkinson's disease. ده الحاجة اللي طالعة في الكفر. في فاكتورز يا جماعة تساعد على تكوين النيو فيسلز اكتشفوها بالسكيميا في الريتنا وفي الهارت الناس عندهم سكيميا هارت ديزيز. حسيت برضه غالي يفكروا حكاية الكورونا هارت ديزيز دي ده ليه الدوبل فاكتور ده IgA هو approved for certain diseases لكن طبعا هو بيساعد في السكيميا في العين. فwhy not to give it to patients with Parkinson's disease increase الفاسكولاريزيشن is it going to help the cells؟ عملوا اكسبيرمنت فيه جابوا مونكي وادوه MTPT Parkinson's disease بقالوا و anyway the video is not showing. So what happened? It created new blood vessels and the Parkinsonian fish disappeared. ده حس الحياة طلع في الكفر احتمال كبير انه الفاكتور ده يمكن لو ما يكون بصورته الموجودة الآن في أمريكا وكده ولا في الاكسبيرمنتس it might be a cure for Parkinson's disease injected right into the substantia nigra and the new vessels might help get new disease. I think it is a vast area. Like the most important is to use a flavor. There are new drugs, new techniques, physical therapy, health, neurology is very versatile. It is going very fast. But Parkinson's disease, although it is going slow, but it is sure. For shortage of time, I apologize for all the technical problems, and I need to stop here to stick to the 20 minutes time. Thank you very much.
Thank you very much, Professor Sheikh. This is very interesting. And I think, Bushra, are you ready? Yes, okay. Right. The second speaker. There will be discussion after the same speaker, inshallah. Okay, from the title, I think, the GI evidence will be presented by Bushra now, and the topic is endoscopic treatment of obesity, bariatric surgery. Does it work? We have to see.
Ahmed Ali Kidai's Parkinson's disease is different because that is due to repeated injuries. It's not due to the natural degeneration function. It's a Polish Parkinson's disease. So it is different entity, different from the idiopathic Parkinson's disease. And even these patients, the response to treatment is not that good. Because the pathogenesis is different.
بروفيسور باكر قال لي عايزه تقولي حاجه لوشيك قلت له في كلام بعد وشيك غير توك والله غير توك
يا جماعه by the way if you talk about genetics and early diagnosis we have made a lot of breakthroughs here in this department. Sarah and myself we describe now a cohort of patients, Parkinson's patients. I noticed they were very I have a patient who has Parkinson's at 8 years only. This is the youngest patient with Parkinson's in the world, proven. And we, one of our PhD students, who I'm his supervisor, now he's in Germany, we found that this family has problem with methylation of dopamine. And Sarah is part of the research. It is published a few weeks ago. Now we have 2 manuscripts which are going for publication as well. So it is genuine, real science coming from this department. Thank you very much.
طيب بسم الله الرحمن الرحيم. So I've been tasked to spend the next 20 minutes or so talking about obesity in general وبعدين the role of endoscopy in obesity. It's no secret that the morbidity and mortality associated with being overweight or having obesity actually has been very long, more than 2,000 years ago. Even Hippocrates have described the ailments of being overweight or obese. Even though in some cultures being obese or overweight is a marker of wealth and health, like in everyone, even now in Sudan, there is the general understanding that being overweight and obese has a lot of problems. It's also no secret in obesity is a chronic disease, and it's almost now a global epidemic in underdeveloped and developed countries. You might be familiar with this map. This is the share of adults that are overweight or obese. And as you can see, this is the percentage of the population. Okay. Yeah. So this is the percentage. So as you see, obesity is most prevalent in Northern Africa, the Arabian Peninsula, and in Australia and North America. And even though obesity is very linked to morbidity and mortality, when you look at the next slide, which is the death rate from obesity, you don't see that the death rate follows the prevalence of the obesity. And this is the marker of better healthcare and health outcomes. For example, in North America, even though obesity is very prevalent, you would expect the mortality to follow that, but it does not. And in our country, even though obesity is not as prevalent, but the death rate from obesity is. And this is just a marker of the general poorer health care and outcomes. This graph correlates the death rate with the BMI in both males and females. And as you see, in the relationship is linear. As the BMI becomes more, all-cause mortality is very strongly related with obesity. And this is correlated to age and to smoking, which are the two other most common risk factors for death from obesity. So this is correlated purely for obesity and being overweight. Now we talked about the mortality. So what about the morbidity? The list is very long. This is all documented that being overweight or obese increases on its own after correction to other factors to all of these ailments: metabolic, cardiovascular, cancer, GI problems, genitourinary, respiratory, and of course psychosocial. So the impact of psychosocial impact of obesity and overweight is found because of depression, stigma, and even patients who are overweight or obese who present to medical care, they are usually mistreated or undertreated by professionals who are supposed to be trained in treating obesity. So the problem is big, and this led to the increasing urgency to treat obesity and to consider it as a disease rather than a lifestyle. So this is a general overview. Of course, diet and exercise is the cornerstone of treatment, but on their own, they haven't been very successful in reaching the ideal BMI. Behavior modification, this is the factor that, because I'm sure most of the people who have been overweight or obese have tried bursts of diet and exercise, but the problem is maintenance of that. So in addition to implementing a diet and exercise program, patients or people, if they are not patients yet, they should have some behavior modification as to how to maintain those habits. Many drugs have been used and experimented. The ones that are now FDA approved are the gliptins, and maybe my colleagues from endocrinology can have more to say about this. Orlistat, which is a malabsorptive medication, has also been used. These are the two ones that are now FDA approved solely for weight loss. Many people use other medications. We all see in our clinics patients who use metformin, and they are not diabetic, purely for weight loss. And if the time allows, maybe we can get the comment of Dr. Salaf or Dr. Zainab about this practice. So all of this led to the use of surgery and then endoscopy to try and have patients lose significant weight and improve their health outcomes. So bariatric procedures have been introduced since the 60s, and many trials and errors have been done. They fall into two main categories. The first category is restrictive, meaning limiting the size of the stomach in particular to limit the amount of calories that the patient or the person is able to ingest at one time. The other category is malabsorptive, meaning to reduce the surface of the 20 feet of small bowel, to reduce the absorptive surface and thus reduce the amount of nutrients absorbed into the body. And then there are the combined. So some of them are now obsolete. Vertical band gastroplasty have been popular since the 70s and 80s and into the 90s, but now they have been obsolete. Jejuno-ileal bypass, which includes essentially having a long loop of small bowel that is out of service. This has also been abandoned, and other things that are still used is the Roux-en-Y, which is a combined restrictive and malabsorptive. It includes the diminishing the size of the stomach, in addition to doing some form of bypass, and some procedures include devices. This has also been popular for a while. It's still in use, which is the adjustable gastric band. This is inserted surgically or laparoscopically with a band across the junction of the proximal third and distal 2/3 of the stomach with an adjustable band. So all of these procedures have been, as I said, introduced since the 50s and all the way until now. The most famous that I will spend some time talking about now is the sleeve gastrectomy. It's the most popular and the least one that has side effects. Bariatric surgery, even though now it has made a lot of strides in the US, there is now a dedicated fellowship to study only bariatric surgery. After the doctors and surgeons do a residency of 5 years in general surgery, then they do 2 or 3 more years specifically about bariatric surgery. So, like all surgeries, there is operative complications, and don't forget, these surgeries are reserved usually for patients with morbid obesity, defined as a BMI more than 40 or more than 35 if combined with comorbidities. So these patients to start with are poor surgical candidates. So that then you can expect more complications with anesthesia, infection, and since most of these surgeries include cutting and anastomosis, leaks from these surgical anastomosis remain to be a problem. Malabsorptive surgeries that include jejuno-ileal bypass, biliopancreatic bypass, duodenal switch, Roux-en-Y, all the types of surgeries that include bypass have led to serious problems with vitamin and mineral deficiency. And of course, there is the economic cost that most surgeries require some form of hospital stay, and this is why endoscopy lately have come into the game. So, is bariatric surgery effective? It is. It is effective. This is the excess weight loss percentage by procedure. So this is the duodenal switch, which is now not of favor because it includes, it's a major surgery and it messes up a lot of the physiologic function of the gut. Is the most effective. It can lead up to 83% loss of excess body weight, not the total body weight at 24 months. Gastric bypass, and the most famous now is the sleeve gastrectomy because it is the most physiologic type of surgery. It can achieve up to more than half of the excess weight can be lost and maintained at 24 months. So this is the sleeve gastrectomy. This is now it is even available, to my understanding, here in Sudan. It's available regionally, and essentially it's a restrictive type of surgery. It started off being open, in which they remove this portion of the stomach and they staple alongside the lesser curvature. Now it's being done vastly laparoscopically, and most recently, this year, the FDA in the United States have approved an endoscopic accessory that gets connected to the endoscope, and it achieves essentially the same job endoscopically. The patient is scoped in an outpatient setting, and this is a suturing device that essentially sutures the rest of the stomach, and there is no cutting done. So what is the, and a multi-center study included about 200 patients who underwent endoscopic sleeve, and it's called endoscopic sleeve gastroplasty, not gastrectomy, because no part of the stomach is removed, it is just sided. And these patients lost more weight compared to controls, about 14% weight loss of the total weight loss, and almost 50% of the excess weight has been lost. So in comparison between the endoscopic surgical gastroplasty and the laparoscopic surgical gastroplasty, hospitalization obviously is required for the surgical one, even the laparoscopic. Return to work is faster with the endoscopic. Average excess weight loss is slightly less with the endoscopic. And again, the major complications are quite rare. They are even quite rare in experienced hands, but they are less with the endoscopic route. And both of them are not reversible. The other endoscopic procedure that could be done and is now available in Sudan actually is the intergastric balloon. When I was doing my training overseas, this procedure was not yet approved in the United States, so we didn't train in it. But it's technically very easy, and I first came to learn about it when I was working in Saudi Arabia. It's very easy. It's a balloon. You give the patient conscious sedation. You insert the balloon through the working channel. First you insert the catheter, then you insert the balloon through a special catheter, and then you inflate the balloon. And you can inflate it up to 600 mLs, and the minimum is 400, depending on the required degree of weight loss. And you inject it with saline with a little bit of methylene blue in it, so that if it bursts, then the methylene blue will appear in the urine and stool, and the patient will know that it needs to be removed. It's quite popular in Saudi Arabia, and now becoming quite popular here in Sudan as well. I'm not a fan of it, and you will know now why. It is effective, so it is used for a BMI which is slightly less. Surgery is usually reserved for patients with higher BMI, more than 35 or 40. These are indicated in Europe for a BMI more than 27, in the US more than 30. I think the Europeans are less tolerant of obesity. So there are contraindications if there is previous gastric surgery, pregnancy or desire to become pregnant, coagulations, and there are complications. Common adverse events, they are very common. Patients feel absolutely miserable after this procedure. يعني تخيل انت بس عندك كوره منفوخه قاعده في بطنك. These patients, they have a lot of nausea, a lot of vomiting. Some of them demand that it gets removed the day after the procedure. And the balloon can migrate, cause obstruction. This is not really common. There could be spontaneous hyperinflation. Gastric juices somehow go into it. And they also reports of acute pancreatitis. But severe side effects are not rare. But the problem with it is really efficacy. It does work on the short term. After a period of misery, that the initial weight loss is only about 6 to 15% compared with the 1 to 5% produced through lifestyle interventions alone. The main problem is the sustained weight loss, because usually we keep it for 4 to 5 months, then it needs to be removed, and almost all patients regain that weight afterwards. I remember I had one patient in Saudi Arabia who did not even that initial weight loss. And the reason why, after I interrogated her, she said that she was drinking liquid chocolate to work around the sensation of fullness. So all of these procedures, endoscopic and surgical, they need a lot of preparation, psychological and social. The patient needs to be on the same page as the patient. And so I personally decided not to, even though it is very easy to put in and very painful to remove. Like I ended up just doing a lot of removal of these cases. It is available زي ما قلت لكم now in Sudan. Patients are known, and now and we tell the patients, you will not lose a lot of weight. واللحظة تطلعها وحتكون بتطرش وعينك طالعة لفترة. Now the most popular clients for this procedure are young females who are going to marry. بيقول لك يا زول تمام بس خدتوها انا بس داير شهرين ثلاثة بس اقدر اخش في الفستان ده وبعد العريس بيقدر يكتب خلاص يبقى في full informed consent, and this is to me this is an indication. طيب last but not, this is the last so there is no doubt إنه these procedures, surgical and endoscopic, have led to, at the time didn't allow to share with you the data, the improvement in outcomes. And I'm sure my endocrinology colleagues, most of cases of type 2 diabetes, they just disappear when the patients lose weight. A lot of cases of COPD, they disappear when patients lose weight. So there is no question, even من ناحية health economics, these countries, they discovered investing in training surgeons and gastroenterologists, even though this equipment and surgical procedures, on the long run, they save a lot of money. You decrease a whole spectrum of medical conditions that are taken care. Like not everyone is successful in losing weight. And here I'm talking about my personal challenge. Losing weight is not easy. One day I had a patient ومعاه co-patient. فالبيشنت المين problem بتاعته is weight loss. فقال لي يا دكتور يا اخي انا فاقد لي وزن, فانا I wanted to quantify it. قلت له نقصت وزن يعني قدر شنو؟ قال لي والله يا اخي قسمت ونص. من كلام ما واضح. قلت له يعني كنت قدر شنو؟ كنت اكثر من كده ب 5 كيلو. الكوبيشن ساكت الوقت كله فجأة نطة قال لي لا يا اخي ده كان كثير خلاص كان قدرك انت يا دكتور. فانا انا ذنبي شنو يعني والله لكن I got the picture يعني كويس. The message to people who suffer from overweight and obesity like I do, if you fail to lose weight, stay fit. لأنه there is a lot of studies إنه fitness level, fitness يعني شو؟ fitness في عمرنا ده إنك تمشي 30 دقيقة 3 مرات في الأسبوع أو تطلع عليك سلم. للناس الأصغر الفتنس طبعا تلعب كورة وحاجات تانية زي دي. So there was a meta-analysis of almost 10 studies. So they looked at, it compared unfit individuals or fit individuals regardless of BMI. Regardless of BMI. If you are fit, even if you have less mortality. And further, fit individuals with overweight or obesity had similar mortality risks as fit individuals of normal weight. So even if you don't lose weight, stay active. And staying active has benefits as well. شكرا جزيلا.
Thank you very much, Bushra. This is very interesting, very and weird also. It is a bit weird, to lose weight. I remember, يمكن أكبر واحد وزنه كثير شفته في حياتي، يمكن ريكورد ذاته كان السيدة أرابيا. he vomited blood. وهناك قفل اندوسكوبي، فهو بره شوية من المدينة اللي احنا فيها، فيضطروا جابوه طبعا شالوه من البيت بويش وخطوه في التراك يدخل كيف الاندوسكوبي روم ولا الحاجة ده ما ممكن. This is the first time we did endoscopy outside في الحوش. We had to transfer the whole equipment outside والراجل شالوه بالوش ثاني. طبعا this is more with obesity. I think the indications are becoming كمان very weird. يعني الحكاية البطة بتاعت الزواج ده بس الثلاثة عشان الفستان يلبس وبعد ذاك يزعوه أي شيء. Who are ladies who are you deceiving? Anyway, very weird. If there is a quick comment about metformin, any quick comments then about Sola? Is it effective? Yeah.
Because metformin initially there are no randomized controlled trials to say that metformin is indicated because it's not FDA approved for weight loss to start off with. So, but we have a lot of non-diabetic young ladies trying to lose weight. They use it. By then, from our just experience, they lose weight, but it is not sustainable, and they regain that very quickly. And the weight loss is not as much as what happens with diabetic patients. Diabetic patients, we all know that metformin works at the level of insulin resistance. Obesity increases insulin resistance. Diabetes has more insulin resistance. So the weight loss we see is more with diabetics. And on the other hand, we have a lot of diabetic patients, obese, who don't want to lose weight, so they don't want to take the metformin. So we have to try to convince them because metformin, as we're going to hear about later in my talk, is one of the first line medications for treatment of type 2 diabetes.
The new medicine called Ozempi, I think
This is the
brand. This is why I'm
okay. You're concerned about that, and then something with the eyes. Some recent studies it's going to the eyes as well. Dr. Bushra alluded to GLP-1 agonist use in weight loss. Examples are semaglutide and liraglutide, and then there's a new one, tirapentide. So those three are FDA approved for weight loss and are used in obesity. Ozempic, you started with, both of they're all the GLP-1 agonists are subcutaneous injections, and they have made a revolution in the treatment of obesity in non-diabetics. They can be used for non-diabetics. To the extent that Ozempic and semaglutide has been يعني بعد فترة انعدم من العالم كله، السوق العالمي كله، and لأنه everybody starting to use it for obesity, and even Hollywood, celebrities in Hollywood are using it because they lose weight very quickly. It's a very, very effective effective drug. Weight loss is with very minimal side effects. They start at very low doses and then you build up the dose. To the extent that once you stop it, of course, when on Ozempic, you have to still be on a diet and exercise. Yeah, you have to be on diet and exercise, and it needs monitoring, ophthalmology. This is one of the recent papers. Dr. Zainab can maybe talk more about that. And then Prof. Osheki mentioned something about the brain. I'm not aware of that now. Like so far, it's a very, very famous drug. Zahar can live 5-6 years, more than that. Even tablets, semaglutide tablets, but the weight loss with tablets is not as much with the injectable form.
Because this is an update session, this is why I wanted.
This is an update session. This is why I wanted to bring this up as well. Because you just take one tablet and use 16 kilos or 20 kilos. It has consequences. It was found that even the rate of depression and suicide increase with rapid and massive weight loss. So weight is not that bad if you keep fit. Shukran.
يا أوشيك زمان أهلنا كانوا بيقولوا قالوا للسمن ماشي وين يا هاي؟ قال ماشي أعدل كل ما ي. فخسارة الكلام ده بقى ما في لا والله اسمعوا زمان يعني لأي واحدة بيقولوا very good كانوا بيقولوا الوحدة للسمن ان جنرال ماشي وين يا هاي بقول ماشي أعدل كل ما ي. فما عارفة الفستان ده حيتلبس كيف يا بشرى.
I think اتكلمتوا كثير في الاوبيسيتي. اهم حاجه بي اكتف يا جماعه. لا جريح لا قطيع just be active. Right. Our next speaker is Professor Ala, as you know. Bronchial asthma is quite prevalent, sometimes difficult to manage. I think Professor Ala will tell us more what is update on the management of bronchial asthma. Dr. Ala, you have 20 minutes.
Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Allow me to welcome you all to the meeting. I'd like to send a special welcome to Ibn Dufati al-Fatih al-Bashir. I'm going to talk about an update on asthma management, and I'll try to be as much as I can evidence-based. And I'll show you what has been happening over the last 2 or 3 years in asthma management. Asthma is a very common disease, very common. Today, about 300 million people are affected by asthma, and that is expected to rise to 400 million by 2025. Now, in this country, we're not at all different. As you can see, that asthma in this country is a big, big problem. And I think the people who practice in the field of pulmonology know this very well, that we have one of the highest prevalences in the world. That is the highest prevalence you can get. And the other thing is that our asthma is very bad. This is bad asthma. So bad asthma in this country is very, very prevalent. And we see this every day. So how do we treat asthma? Now we treat asthma, I think everybody who practices in the field of pulmonology now uses GINA guidelines. So the next question is, what is GINA guidelines? Now GINA guidelines are guidelines that have been established in 1993 by the WHO and the NHLBI. That's the National Health of Lung Blood Institute in the United States. Although it has been a combination venture by the two, it's an independent body. It's totally independent. And their guidelines are updated every year, depending on the evidence that is available, and it's evidence-based. And what is even more important is that GINA guidelines are very much concerned with translation medicine. And they are involved in translation medicine by advocacy. They try to bridge the gap between findings of research and clinical practice. That's translation medicine. And they have lots of advocacy, and you can certainly access the GINA guidelines. They are free online. You can get the whole document free of charge, and you can also get pocket documents for treatment of different types of asthma, for example, difficult to treat asthma and the rest of it. And I think this really has replaced what in the past was BTS guidelines, that is British Thoracic Society guidelines, and ATS guidelines, that is American Thoracic Society guidelines, and now everybody uses GINA guidelines. So if you like, it's now become the Bible, if you like that terminology, or in the practice of pulmonology as far as asthma treatment is concerned. Now, and this is what the GINA guidelines tell us to do. Now, deliberately, I've given you an old one. Now, we treat asthma in a stepwise fashion. So if you have a patient who has mild asthma, you put them here. If you have a patient with difficult asthma, you put them there. And when you see the patient for the first time, where do you put them in this stepwise fashion management plan? It totally depends on your clinical judgment. There are no hard and fast rules. So you see the patient, you take the history, you examine the patient, you do the appropriate investigation that you would like to do, lung function, eosinophils, IgE, or whatever your decision is, and then you decide, well, this patient will do better if I put them in step 1 or 2 or 3, or step 6, when we see very difficult patients. And when you see the patients, and it's always recommended that patients should come follow up, then you will decide on what the patient has been doing, whether to step them up or to step them down. So if somebody is getting better, you step down. And the reason for this, because we're doing medications, we're using medications which have lots of side effects. This is number 1. And the other thing is, we're using medications which are very, very expensive. And this is the other problem. We did an exercise in my unit, and we found that treating chronic persistent asthma is more expensive than treating heart failure or diabetes using just generic formulation. The only thing that was more expensive to treat in this country compared to asthma is treating chronic renal disease. But definitely more expensive than treating chronic heart failure and more expensive than treating diabetes. So you see the patient and then you step down. Now, it is generally recommended to gain the confidence of the patient that when you see a patient, you start at a step which is a little bit more than you think that patient needs. So when the patient comes, it would be best to step down rather than step up. And the reason for that is if you give the patient adequate treatment, you gain their confidence, it will come back to you. But sometimes you get patients, and when they come back to see you, you step up. And the problem has always been this one, step 1. And step 1 is called mild asthma. Now, if you just look at the definition of mild asthma, this is rather a strange definition. It does not depend on lung function. It does not depend on the type of exacerbation that the patient had. It all depends if that patient needs as needed medication more than twice per week. So, and you use SABA. SABA stands for short acting. Professor Fadel was just saying to me that the whole of medicine has become abbreviations. SABA stands for short acting beta-2 agonist. So if somebody needs SABA, short acting beta-2 agonist, more than 2 times per week you step and they need it more than time per week, you say this is not mild asthma. So we're going to get you to step 2. But lung function has nothing to do with saying this is mild asthma or not. The degree of exacerbation, whether the patient has been admitted to hospital or whatever, has nothing to do with that. So the definition of step 1 is rather shaky. It's not a very good definition, but that's something that has been going on for more than 50 years when ventilator was invented. And people said, well, is it really correct to call this step 1? And they've looked at this, and the way to look at this is to research it. And what they found is very intriguing. What they found is that patients with apparently mild asthma, these are the people that we treated at step 1 of the GINA guidelines, constitute about 1/3 of adults with acute severe asthma. That's a lot. And they constitute about 16% of patients with near fatal asthma. And that's again a lot. And they constitute about 1 in 5 of patients dying with asthma. And that's a lot and very dangerous. So the calling these patients as mild asthma is not correct. And we have to be very careful about these people, because that gives a very false sense of security that these people are okay, but they are not. They can still die from asthma. One in 5 of them, or 1 in 5 of deaths from severe asthma can be from this group. And the other thing is that the triggering factors for exacerbation can be many. Now, probably the most important trigger for exacerbation is viral infection, especially during the winter. And that is why our clinics are extremely busy now, because of viral infections. Pollen grains, certainly, especially during the autumn. And pollution, if you live in a large city, and I think Khartoum now is a totally polluted city. And the other thing is concerns with oral corticosteroids. We prescribe them for asthma. They are life-saving. We don't hesitate to prescribe them. But if you start giving them many times, they do have side effects, especially in terms of osteoporosis and cataract and diabetes to a large degree. So, and again, when people looked at the use of SABA, that's short-acting beta-2 agonist, or Bachatactin Ventolin, they found that for patients who use more SABA, the mortality increases. And the statistical for this is very overwhelming. And for people who use corticosteroids, if you use more corticosteroids, you reduce mortality. That is inhaled corticosteroids. And if you use more SABA, the mortality increases. So when you put all of these together, this is given rise to increased concern about, number 1, calling these people mild asthma. They are not mild. And number 2 is to give them SABA. Now, SABA is a bronchodilator, and we know now that beyond the shadow of a doubt that asthma is an inflammatory disease. And bronchoconstriction results from the inflammation. So if for example, somebody has headache as a result of a brain tumor, and you treat the headache and you don't treat the brain tumor, they don't do well. This is only logical. So if the bronchoconstriction is as a result of the inflammation, and you do not treat the inflammation, because SABA does not treat inflammation, Ventolin is just a bronchodilator, it's not an anti-inflammatory, then you're not doing the right thing. Now, there was consensus among the respiratory community that the treatment at step 1 should be revisited. And it should be revisited because of all the statistical data. Some of it is very concerning in terms of increased mortality. And we have to revisit it and see whether we can do anything about this or not. Now, this is what has happened. Now, there was a group of academics in the respiratory community who sat around the table and they said, well, how can we revisit this? They were very clever, very astute academics, and then they decided this is the way they should do it. Now, they should design studies, and they should design studies to look at this. Now, just for the sake of the juniors who would like to pursue an academic career, these are the ethos of good research. If you have a problem in medicine that you would like to find an answer to, you should conduct good research. And good research has an ethos. And the ethos of the good research is this one, is that your studies should be novel, i.e. designed to fill gaps in knowledge. And this is very important. You just don't do research for the sake of doing it. But you should get an answer by doing research. And the study design should be sound. So your design should be randomized and controlled. Whatever randomization you use, however you control for the study. But you should have a sound design. And the studies should be appropriately statistically powered. There is no benefit at all from doing a study that does not give you an answer, because you've only studied 6 patients, for example. You have to do a very careful power calculation to be able to get answers to endpoints by the time you finish your research. Otherwise, that research is not beneficial. And the other thing is you should really have robust endpoints, very clear endpoints. Reduction in morbidity, reduction in mortality, and the rest of it. But it is not just that the patient is feeling well, for example. That's not a good endpoint. That's something that is not reproducible. And which is very important, appropriate dissemination of your research, and that is publishing it. And you publish it in reputable journals that have a good impact factor that would reach the medical profession, would reach us as audience. So anyone who wants to pursue an academic career, I think they should always remember these important facts about research. That's good research. Otherwise, it's not good research. Now, these people sat and they conducted good research. And I really made copies of these publications, and I will talk about them. But I would like the audience, especially the young participants of the audience, is to go and read these studies. This is really state-of-the-art science. It's beautiful, really beautiful. And that is called Sigma 1 and Sigma 2 and Novel Start studies. And as you can see, they have been very appropriately disseminated in that they were published in the New England Journal of Medicine. And I'm sure you know what it means. That is the journal that the highest impact factor in the world. Okay? And the fourth study is called a practical study, and that was published in the Lancet. And the Lancet has the second highest impact factor in the world. So this research has been done appropriately with all the criteria that I stated earlier, and they have been disseminated appropriately. So what did they tell us? That is the next step. So the first thing is to compare it with as needed SAVA. So that's a head-on comparison. We have step 1, the guidelines told us to use SAVA. So you want a new intervention, and you just want a head-on comparison between the two to see which one is superior. And that's a very robust design. And what they have shown us, and the other thing is to compare it with step 2. And if you remember, step 2 is using ICS, that is inhaled corticosteroids. And the reason for comparing it with step 1 I have shown you that because that's where the problem is. And the other thing is comparing it with step 2. I think the importance of that is that because of the people who are not doing well in step 1 will be upgraded to step 2. So it would be appropriate and important to see whether that upgrading is correct or not. So you have a new intervention that you believe from science that it works best, and you have to compare it with what it exists, where the problem is, and what it exists, where the problem may be when you step up. And these studies have shown that there are small differences in other outcomes measures of using the first one. They've shown that the risk of severe exacerbation is definitely reduced by about 60%. By about 60%, that's a lot. If you use fonvitrol and in ICS instead of SAVA. And the other one have shown that the summary of this is that it is not inferior to using ICS alone. It is definitely not inferior to using ICS alone. And as you can see, they've quoted the studies that I've shown you, the Sigma 1, the novel start studies, the Sigma 1 and 2, and the novel start studies, and the practical studies. These are the big gun studies, if you like, that I've shown you. So obviously these studies that have been designed and conducted and published gave answers to questions, and that's beautiful, because now they're telling us what to do. And they went on and looked at outcomes independent of baseline features. They played with the statistics. So they just look at it head on, and they say, well, what are the baselines of these people? Were they different? And they go back to baselines. And I think for comparison with SAVA, they've always shown that a combination of fonvitrol and ICS. Fonvitrol is a LABA that has a quick onset of action, for those who may not be familiar with it. So it acts as quickly as salbutamol, but it acts for a very long period of time. So it's essentially a LABA. LABA stands for long-acting beta-2 agonist. So in essence, if you use fonvitrol plus an ICS, and in these studies they use budesonide, they have shown that that's definitely better than SAVA, and it is definitely not inferior to ICS alone.
In mild asthma. In mild asthma, right? In mild asthma patient.
Yeah, definitely step 1 is mild asthma, but when you go to step 2, you get a little bit more than mild asthma. But I think I explained why in ICS, because that is where you step the patients to. They wanted to know simply, are we doing the right thing by stepping up to ICS alone or not? And then they looked at and this is another way of doing things. Now I've shown you the 5 big studies, the big guns as I call them, and I've shown you the evidence that it is superior to SAVA, and it is not inferior to ICS, and in some aspects it's superior to ICS. And then there are so many other small studies, and when you have many small studies that are not as beautifully designed as the biggest studies, then what you do, you pool the data, and this is called meta-analysis, and I'm sure that some of the junior staff know what meta-analysis is. And in the meta-analysis, they've shown that there is a 55% reduction in severe exacerbations compared with SAVA alone. And they've shown that the similar risk of severe exacerbation at this daily ICS needed SAVA. So again, the meta-analysis is showing us superior to step 1, not inferior to step 2. And they've shown that there is, in further meta-analysis, they've shown that the combination of fonvitrol and ICS is superior to ICS alone in terms of emergency department exacerbations, and they're definitely superior to SAVA. All the studies and all the meta-analysis have shown that the findings are definitely superior to SABA alone. Okay. And then they went on and they did more meta-analysis, and they again come to the same conclusion. Definitely SABA is inferior, and ICS is not inferior, and in some aspects they are even superior. So, where do people go from here? And I think it would only be logical that you sit down and change guidelines. Okay? You only sit down and change guidelines. And this is exactly what people did. They said, well, let us have track 1, which is the preferred treatment, depending on the findings of the research from very good 5 studies and from a number of pooled data from meta-analysis of many studies that were not as good as the 5 studies, but they're still not bad. And they said that the preferred treatment, because for step 1, is using ICS formoterol combination as a reliever to reduce the risk of exacerbation compared with using SABA reliever with similar symptom control and lung function. So step 1 has been changed now. Okay? And then they said, well, we have track 2. And track 2 is not as good as track 1. But sometimes in some countries, as I told you, that the GINA is an international thing. And they were very aware that in some countries of the world, you cannot implement all the findings of the GINA because of the health structure of the different countries, and certainly because of the economy of health, and certainly because of the availability of drugs. And they said, well, in this case, if you use a SABA, you should not use it alone. You should always give an ICS with a SABA. So never SABA alone. يعني بمعنى آخر يا إخواننا، مثلا إنه الزول يجيه أزمة ويبخ أخذ فنتولين، this is oxylene now. It doesn't work, it's dangerous. And this is the summary of it. So this is step 1. So in step 1, and they combine step 1 and step 2, you use a combination of as needed low dose ICS and formoterol. This is the best option. This is the best option for step 1. And the other thing is that you use a reliever as needed plus low dose inhaled corticosteroids all the way up to step 5. يعني بمعنى آخر, using a Ventolin inhaler is needed is now obsolete. Okay, and then this is track 2, which is less. So you take an IS, you always take an ICS whenever you use SABA. يعني عندك بخاخة بتاعت فنتولين، يكون عندك بخاخة بتاعت فلوتوكيزون، أو بخاخة بتاعت بيوديسينايد، أو بخاخة بتاعت بيكلوميثازون. Don't take Ventolin alone. Okay? And this is the way that the guidelines have changed, and this is the way how we treat asthma in the modern day. And I think I have shown you how it was created, and that's important. That's the beauty of science and research and the beauty of academia. And thank you very much.
Thank you very much, Professor Ala. Right, as you can see, it's a bit complicated. It's not as easy as it shows. Right. Okay, we welcome Dr. Fatah. Welcome Dr. Fatah. زي ما قال Professor Ala هو قبعته، ما دارين نقول قبعة، لكن قبعته دي ذاتي أنا ذاتي عندي ارتباط بها آخر، مع إني بعيد منها. هم اللي امتحناهم ودرسناهم أول مرة لما جينا الكلية هنا. Anyway, do you have any comments, Fatih, about what Professor Ala mentioned?
Professor Sarah said about Professor Sheikh in respiratory medicine in Sudan, when Ala talks, we just learn and enjoy. No more
This meeting is sponsored by Azad Company وهم حيجيبونا some refreshment وسندوتشات لكن حيجيبوها على الساعة 10. Later we continue. We delay the break for a while. Our next speaker will be Dr. Ahmed Ali. It is cardiology. And his title is an update on something on cardiology. So we'll see this something. It might be heart failure, acute coronary syndrome, or angiogenesis treatment, heart disease. So we'll just wait and see. Right. طيب دكتور محمد علي الطاهر.
شكرا يا بروفيسور. و really enjoyed the speakers يعني outstanding ما شاء الله. I also would like to add my voice to علاء برحب بأخونا دكتور فادح and on your behalf نرحب ببروفيسور عمر زايد. A question to Professor Ala, like the surviving sepsis campaign, لما بدوا كان عندهم terms كان عندهم حاجة اسمها severe sepsis وبعدها septic shock وسبسس ساكن، فلقوا انه قصة severe دي ما شالوها كله من بقت sepsis بس وسبتك shock. وما أعرف هل ممكن معناها الأزمة يكون عندك بس أزمة ما في السكيل بتاع أنها مايلد ولا ستيب 1 ولا ستيب 2 ولا ستيب 3 تشاهد أزمة لأن أزمة فعلا لا زالت أكيد ديزيز. إيش رأيك؟
شكرا محمد علي. أنا أعتقد the term mild definitely obsolete now that it's been taken off. لكن the steps are there because just you have to put the patient somewhere. What's happened, in actual fact, there have been quite a few new things in asthma. I think if you notice on the first slide there was a step 6, but on the recent guideline there is just only to step 5. So what used to be step 6, now they've taken it off and they call that difficult asthma. And for people who used to be in step 6, they don't call them severe asthma, but they just call them different asthma phenotypes. So anything above stage 5 now we phenotype. It obviously did not have the عشان talk about the new thing regarding phenotypes for the patient at the upper level of the scale.
Right. Ala, what about oral steroids? Do you recommend or just go those continuous or intermittent?
Oral steroids only for exacerbations. Like we do not want patients to go on long-term oral steroids because of the very serious side effect. Now, the patient that used to go on repeated courses of oral steroids or to be put on maintenance dose of oral steroids with the difficult patients at step 6. And all these patients now get phenotyped to see whether they have eosinophilic asthma or whether they have neutrophilic asthma. And what we use for them is now we use biologics. And there are different biologics that have been tried for difficult asthma.
And what about anticholinergics, Professor Alan?
What we do now, we use anticholinergics in step 5, and we use long-acting. We use LAMA, which is long-acting antimuscarinic agents, and they've been shown to be very effective. Now, the new player in the market is tiotropium, which is a long-acting LAMA, and we use it at step 5.
What about gene therapy, Alan? Gene therapy in asthma, like you
I'm not aware of gene therapy in asthma. Bashir, okay.
Thank you very much for the elegant topic. I have very intriguing question that comes to my mind mind for a long time. We think this asthma is an inflammatory disease, and certainly it has immunological, basis. I know people use immunological. Is there any place for immunosuppressants in patients with bronchial asthma? I have never heard of this used routinely. I heard somebody mentioning some of the B cells now inhibiting compounds, for bronchial asthma. So, where is the place of immunomodulation or immunosuppression apart from just the biology? Can we use azathioprine, for example?
Yes, they've been used. We've used methotrexate for treating difficult asthma. لما كنا في انجلترا كان فوق ان الناس يستعملوا methotrexate in difficult asthma. And we've used it.
Then using it high mortality, very expensive medical care or rudimentary care. Why don't we step for the medical business?
والله يا شيخ الريزلت have been disappointing with methotrexate. And that is why people now, the new kid in the block is biologics. So now very expensive. Biologics are very expensive, and anti-eosinophil treatment is also very expensive. But luckily enough, really difficult asthma is not common. I think you certainly get very poor patients who have very difficult asthma who would need biologics, but the hindrance is cost.
Will you take the risk of giving them azathioprine, for example, from the rural areas? Or now we are using them in vasculitis because we don't have cyclophosphamide. Don't have biologic, very expensive. And these people have very bad outcomes. So weighing the things.
The evidence does not support it, but I suppose that in some patients you have to tailor things to availability.
Why not to run a small trial and see this?
The methotrexate trials with asthma have been done I think I was about 20, 25 years ago, and people used them for some time. I think they were very disappointed with the outcome. That is why they changed the new generations of antisuppressant biologics.
Just waiting, we have some problem. I think the problem is the diagnosis of Professor Ala. What about what we call asthma mimics? The asthma mimics, and one of them is gastroesophageal reflux disease. We see some patients who are referred to us, and they tend to be just reflux disease. I think.
between asthma and GERD.
Yeah, but it's not but it's not asthma. Yeah. GERD is GERD. It is feeling of the acid. Yeah. So, could you tell us more about this asthma mimics?
This is what we tell the registrars all the time. If you get a patient with asthma who is not improving, you have to sit down and go through a list. And the list includes COPD. And interestingly, it includes heart failure. It's amazing how often you miss heart failure clinically. So COPD, failure, gastroesophageal reflux disease. In covering asthma, you have to think of upper airway disease, i.e. post-nasal drip. And then you have to think of the overlap between gastroesophageal reflux disease, and upper airway disease. And then you have to think of the difficult asthma syndromes. These are the vasculitides, pulmonary vasculitides that present with wheeziness. And then you have to think about two conditions in the past. The terminology now is becoming less popular. One of them is called brittle asthma, and one of them is called brittle asthma type 1 and type 2. These are the asthma attacks that come entirely out of the blue, or these are the asthmatic patients that they don't have eosinophilia, they have neutrophilic asthma, but they are symptomatic all the time. And I think the last one is the overlap between asthma and COPD. Exercise asthma. حسي في النيو جايد لاينز بيقولوا ان الاكسرسايز بعد كده لما بتستعمل when you use SAPA you should always use ICS with it. Again, never use salbutamol.
Also, I think for teaching point of view, there are still people in Sudan use antihistamines for bronchial asthma, and we are seeing some of our students. I think there is a lot of public education that asthma is allergic disease, but it does not need antihistamine. Unfortunately, I see doctors even prescribing cough syrups and antihistamines for bronchial asthma.
Absolutely, which is wrong. And the other thing is ketoprophene. Ketoprophene don't work in asthma.
Don't work in anything.
Antihistamines, true. Antihistamines don't work in asthma. And there are people who use oral beta-2 agonists. They use oral SABA. هو الفنتولين. Nobody uses هو الفنتولين في العالم كله. وشراب الفنتولين.
2 points. The first point about GERD. GERD is a well-known mimicker to asthma. And if you ask any respiratory physician, will tell you he had treated many patients where their asthma became controlled only after adding PPIs. But if you read in all the GN protocols, if you take it for long years, there is no significant improvement in controlling asthma by PPI. So it should not be used as frequently for treatment of asthma. This is second one. Secondly, from our colleagues in north of the valley, from Egypt, a lot of our patients, they come from there with desensitization. You are allergic to that thing, we give you that and that. That will not work in treating asthma. If you find the patient is allergic to cats or to pollens, if you do, it just depends on this sensitization. It's not very useful, but it's very often used in our patients coming from Egypt. Thank you.
Dr. Ahmed is ready to deliver his talk.
Bismillah ar-Rahman ar-Rahim. Good morning. Well, thank you for your patience. I'll be presenting an update on cardiology. I thought I should be presenting on some of the trials that were published last year that might have impact on cardiology practice for non-cardiologists, i.e. for those who practice general medicine or might be interested in knowing things that might impact their patients directly or indirectly. A lot of obviously technical studies have been published, but I think beyond the scope of the general practitioner. I will start by the results of the Global Burden of Disease study, which has been going on for 30 years now, and has been traditionally published in the Lancet. And last year it was the 30 years update in the Lancet. However, in the last edition of the JAC in last year, they talked about the cardiovascular data which were extracted from the global burden of disease over the last 30 years. I know the slide might not be projecting you very well, but again, the data were from the study was conducted over 30 years, ended 2019, the data collection, and it still remains, till 2019, cardiovascular disease remained the major cause of morbidity and mortality worldwide. We still have not got over the cardiovascular disease. And I know it's not projecting well, but I'll try to read. On the column here is a... Huh? Yeah. On the column here, I'll just try to read it. It says rheumatic heart disease, ischemic heart disease, ischemic stroke, intercerebral hemorrhage, subarachnoid hemorrhage, hypertensive heart disease, and of interest is this red color, which is ischemic heart disease. And these are different regions of the world. So it seems that in the different regions of the world, still ischemic heart disease is by far the commonest cause of cardiovascular death across the board, whether it's high income, middle income, or low income countries. And yet we also have an amalgam of other diseases, rheumatic heart disease, which is disease of poverty and low income countries, as well as complications of CVAs, whether hemorrhagic or non-hemorrhagic, is also leading the cause of death worldwide. This projects well. So if you look at the cardiovascular disease, in order of the most important important causes of death, and that is, which is a measure now of quality of life, how many days are lost because of disease. So ischemic heart disease is by far the #1 cause of deaths worldwide, and the #1 cause of cardiovascular mortality. Followed by stroke, non-hemorrhagic stroke, and then intracerebral hemorrhage, hypertensive heart disease, rheumatic heart disease, AFib, subarachnoid hemorrhage, other cardiomyopathy, other cardiovascular disease, aortic aneurysm, and you can go through the list. It's available as free access, obviously. All the burden of disease articles within the Lancet or JACC are free access. So you can go in there and take a look. So it seems cardiovascular disease and ischemic heart disease are still leading the way now across all income countries across the world. And the global burden of disease not only projects the causes, but what are the attributable factors that lead to these. Ischemic heart disease is a disease that has multiple risk factors for it. So when you look at attributable risk factors for these things, hypertension is #1. Hypertension is the most common non-communicable disease in mankind, and it is the major risk factor for ischemic heart disease, strokes, hemorrhages, etc. Followed by dietary risks or cholesterol, exposure to pollution, and in driving today to a shop teaching hospital, العربية لما يكون زي حقيقة الكونديشن ما شغال فتح القزاز يفيد البوليوشن صح يفيد البوليوشن في منتصف الخرطوم terrible pollution. I was thinking somebody should do pollution test in الخرطوم. It's terrible. يا عشان مع البومبان ده والحياة السلفرز الحي amazing. لا ما في حاجة حامية كيف ممكن عليك مراية الله فوق بس يا ما في. So I'll talk about some of the major studies published recently during the last year. And I thought Invictus trial is the one I'll be starting with. Invictus trial tried to test one of the novel anticoagulants, which is rivaroxaban, in patients with rheumatic mitral stenosis, significant mitral stenosis of less than 1.5 centimeters square. Of note, one of the, published in New England Journal of Medicine, one of the co-investigators is Ahmed Said, and Sudan has contributed a significant number to this paper. And we were all hopeful that patients with rheumatic heart disease, especially mitral stenosis, can give them rivaroxaban, they go home, wherever they are, and they usually displaced people far away from major cities. INR is a problem, and the problem is solved. And lo and behold, rivaroxaban did not perform well. Traditional warfarin was better than rivaroxaban, more protective when it comes to stroke. So now, we were hoping the guidelines was changed. We can use rivaroxaban for valvular AF. Remember, so DOACs or NOACs are #1 now for non-valvular AF. And by definition, non-valvular AF are AFs not associated with mitral stenosis or patients who have prosthetic valves. So if you have mitral stenosis, the guidelines won't change. Warfarin is here to stay. And that's I advise you to read about the Invictus trial. Very interesting. So we have to stick with warfarin with all its problems. For now, when it comes to valvular heart disease, I don't see the guidelines changing. We have tried before 78 years back the Epigatran on metallic valves. It also failed. So that's why the guidelines have not changed. If you have a mechanical valve, you can only use warfarin. NOACs have no place now in mechanical valves. There's an ongoing trial on apixaban and mechanical valves. We have to wait and see what that trial will show. But in my mind, warfarin is going to stay as the main choice for anticoagulation in valvular AF.
A tissue valve is okay.
Yeah, tissue valve is not a it's not a mechanical, it's not a mechanical valve, so you can use NOAC as a tissue valve. Anyway, tissue valves does not need anticoagulation per se. And you have AF with it, you can use NOAC or DOAC. But mechanical mitral stenosis less than 1.5 centimeters square. And then we have the ADVOR study, used an old drug, which is acetazolamide, in heart failure. Every patient who got into hospital with heart failure received the usual IV furosemide, and on the other hand, received IV furosemide plus IV acetazolamide, a cheap drug that is generic. Acetazolamide patients did better. Time for patients to become euvolemic and hospital stay was reduced significantly with acetazolamide. Takes from this study, one, acetazolamide was given IV. What we have in the market is oral, obviously, used for eye disorders, intracranial hypertension, things of the sort. Acetazolamide causes a lot of depletion of potassium and magnesium. That infusion was given in a mixture of D5W with potassium, magnesium, and phosphate. And I saw some doctors start giving acetazolamide oral. So you have to be careful. The study was IV, and these patients were supplemented with potassium, magnesium, and phosphorus. So if you want to use that, make sure at least you measure these electrolytes. Because we know hypokalemia, hypomagnesemia in a patient with significant reduction in LV function can produce arrhythmias, VT, and death. So you have to be very careful. But I think there is a lot of promise, and maybe in the future we see oral acetazolamide, a very cheap drug, coming into the drugs that we can use to expedite diuresis and reduce hospital stay. And this also made it to the New England Journal of Medicine, because heart failure is a major issue, and people are looking for affordable drugs for this epidemic of heart disease. The time trial, and I think we have alluded to that, Professor Bakr, in one of our hypertension meetings. It's a very interesting UK-based trial, and it answered a major question, because there's a lot of debate. If I have hypertension, when shall I take my medication? In the morning, in the evening, shall I split them? What's the best time? And for now, this is the largest randomized trial, UK-based, and the good thing about UK-based studies that are funded by the NHS there is that they look for cheap, affordable solutions, unlike trials coming from North America driven by big companies, and they only test expensive drugs, because if they come positive, a company will become very rich. It's a very simple trial. I think it was presented at the European Cardiology Society meeting, and it basically showed it doesn't matter. Take it in the morning, take it in the evening, it's the same. No change, blood pressure control, no change in outcomes. Good thing. So I tell the patients, you can take a medication any time of the day, just whenever it makes you feel, more compliant. Some people are more comfortable and more compliant taking it for the bed. So in the morning, so you can take it anytime. Just choose one time of the day when you think that you will be able not to miss your medication, and take that and just stick to that time. Because a lot of problems I see is they tell you, I take this medication and I feel like I'm a it doesn't make any sense. You take a pill now, the pill starts to work in an hour or two. It doesn't matter, it doesn't work. All these antihypertensives are meant to dissolve slowly in your small gut, so they produce 24-hour levels. And when you take a pill in the morning, the pill from yesterday is still working. The half-life is quite long. So you have to advise patients that these pills work very slowly. They can take combination pills at the same time, not with hot pill. Pills don't get absorbed within half an hour. It takes hours for these pills to dissolve and produce that effect. And it's, I think, one of the important trials when it comes to practice. And this is the last trial I will present. This, I think, is a trial that shocked the cardiology world. We were expecting something quite different. They took patients with ischemic cardiomyopathy, profound ejection fraction drop less than 35, who were stable, not having angina. We're not talking about patients with chest pain, comes to the emergency room with chest pain. These are patients who have heart failure, found to have reduced systolic function, but they're not complaining from angina, and they are from the community, outpatients. So they divided two groups, those who showed significant ischemia in a large area, and then they performed PCI and in a group, and the other one kept them on state-of-the-art therapy, which is quadruple therapy. RAS inhibitors, beta blockers, melanocorticoid, and SGLT2 inhibitors. Lo and behold, opening vessels with large territory of ischemia and stable, i.e. no active ischemia, no active symptoms of ischemia, did not improve outcomes. So if you have ischemic cardiomyopathy from this trial, and you're not having symptoms of angina, stable patients, now there seems to be no evidence. That took a lot of chunk from our practice, a lot of money from the hospitals. So cardiologists were not very happy with this. So, because of systolic dysfunction, they only excluded left main. لازم نعمل لك قسطرة، لقى فضيك 3 شرايين، طوال العيون في البرايفت. نصليها dilatation 3 sessions، لما رجليك ما يجروش حلو. But that's not working. في الشعب is good news because we tell them no PCI, go home. But however, the debate remains one. Is it important to look at the coronary in patients who have LV dysfunction and risk factors? I think yes. At least to know if this is ischemic or non-ischemic, for 2 reasons in my mind. One, if they're ischemic, you want to give antiplatelet and high-dose statins and maintain their LDL below 70 to prevent future myocardial infarction. Because some of them do become unstable. The second thing is to know how to respond to chest pain. Non-ischemic cardiomyopathy is chest pain. It's different from somebody who has, we know how ischemic cardiomyopathy has been stable, and we know ischemic heart disease is not it progresses, so you apply corruption in the future. But beyond that, treating the vessels with PCI and not bypass seems to have no benefit. The STITCH trial conducted more than 15 years ago, which did bypass in patients with severe systolic dysfunction over 10 years, so that bypass improved outcomes. And we have a dilemma. At that time, we did not have all these medication. So the questions remain, is this true? Will this trial be reproduced in other trials? This PCI? What to do with bypass? Would use old medication? Is the new medication so good that the benefit from PCI has become so small? And I think this has caused a lot of confusion in the cardiology community. And now we don't know how to deal with these patients. But for now, if you just give medical therapy, might be very good. All right. And that's how it is called, the revived BCIS. BC stands for the British Cardiovascular Cardiac Intervention Society. Again, I like the UK-based studies. They look at simple solutions, cost-effective, they're government-funded. So really the interest of the industry is small or non-existent. And how they look at the graphs, they just simply overlap. And this takes us to the last thing. I think I look at the guidelines from last year, a lot of guidelines. I think the heart failure guidelines from the American College of Cardiologists came last year, from the European Heart Society came back 2 years ago. But now they're both agreeing a few things. One important thing is the quadruple therapy. So they came from last year, and this is the top 10 take-home messages from the guidelines themselves. I think this is where we have the agreement. This is where the power for heart failure treatment comes from, quadruple therapy. We have 4 medication classes that have shown to improve outcomes significantly. And now SGLT2 inhibitors, a class 1 indication for heart failure with reduced ejection fraction across all the board. Canadian guidelines, European guidelines, American guidelines, And I think the good thing is we will be seeing generic dapagliflozin very soon in the market, very cheap. So the four pillars of heart failure therapy are RAS inhibitors, and all guidelines now prefer ARNI, the angiotensin receptor neprilysin inhibitors. The one available here is, or worldwide, we have one agent, which is the valsartan sacubitril combination, sold in Sudan as Uperio, or worldwide as Entresto. Comes in 50, 100, and 200 milligrams, and is given twice daily. And if you don't have that, you can use ACE inhibitors or ARB. They're expensive. And I'll tell you one last thing after I go through the slide. Then beta blockers. I mean, the beta blockers that are approved for heart failure are the carvedilol, metoprolol XL, succinate, glutarate, كازاماريكس بيتالوك, زيتوكي هنا في السودان. الشort acting is not as good as the long acting. And the bisoprolol fumarate. These are the three agents that have shown to be of value in heart failure and the ones approved for heart failure. The mineralocorticoid antagonists, spironolactone and eplerenone. These are two drugs now we have and the most widely used. Both are available in the market now. And now we have SGL2 inhibitors, dapagliflozin, which is sold here as Forxiga, فواحد مرض من تركيا اسمه Forxiga, and empagliflozin, which is sold worldwide as Jardiance. 10 milligrams. It comes in both come in 10 milligrams and 30 milligrams. 30 milligrams are used by diabetologists. All the studies on heart failure use only 10 milligrams. So 50 milligrams for heart failure. These are expensive. ده في السودان بيكلف 250 الارمي 250,000. Beta blockers are cheap. Bisoprolol is they're cheap. في عندنا مليون براند local. Spironolactone is produced locally وفي ابليرنون مصري cheap. SGL2 inhibitors الاصلي هسه بتاع استرازينيكا فوركسيا بيكلفها كم 20,000. ده كم 20,000 ده 2000 3000 ده 2000 3000 ده 52. So 80. So maybe around 80,000 or 90,000 pounds per month. My take of things, if they can't afford this, insist on just SGL2, MRA, beta blockers and ARB. That's my personal take, cheap mass. If they can afford 90,000. إذا عنده 30,000 خليه يشتغل ده وده بيقضيه 30,000 ARB كان مسارتان ما بعرف السارتان أرجي. لأنه بسعر الارني بيقدر يشتغل 4 دقائق، بسعر الارني واحد بيقدر يشتغل ARB، بيتا بلوكر، MRA ودافاجليفلوزين. Dapagliflozin generic now will be less than 10,000. It's in the process of being. We have asked the visa to fast track a number of companies, and their price will be less than 10,000. They're going to. It's in the fast track. I expect within 6 months to feed generic dapagliflozin. So that's my take. Poor man's quadruple therapy: ARB, beta blocker, MRA, and SGL2 inhibitors.
Diabetes, statins, what does
والله yes, أنا أفتكر إنه patients with heart failure come to me they دواء كتير. I tell them one thing: you don't use medication, you won't live for 2 years. You get a choice. Take 4 medication or die within 2 years. Which one? مرض كتير ولا دواء كتير؟ هذا ما فقرا، ما عندنا محايا من الديار الجماعة. That's a term, it's really, it's a death, he died. With all these medication, 17% with these patients, 70% will die within 2 years. If they don't take it, more than 50% will die within 2 years. You have a choice, so عم له خيار لك انت. ولما ينوم بالليل نفس مقطوع بعد يمشي الحمام والله 10 هو يبلع. المشكلة بيبقى كويس بعدين يرسل الدواء. I mean that's the end of my talk. Thank you very much for listening.
Thank you very much, Rahman. Yeah, I think the take-home message or conclusion is a bit rough one, isn't it? But sometimes we have to swallow bad things, you know. Whatever, and hope that it might improve. Yeah, the cost and the money is a problem, it's a big problem. But أيوة.
Thank you very much for your presentation. لكن أحمد
تمام بنقول للعيانين اخذوا الدواء عند النوم دواء الضغط لسببين كويس وانت طبعا فننت الحكايه لكن حكايه النون الديبنج تحت الهايبرتنشن والبادي بيس والحاجات اللي هي الموسم انه وانا لما ياخذها عند النوم يعتبر
I think that's the reason why they did this study, because there was theoretical benefits for taking blood pressure at night time. But as you know, sometimes theories do not survive randomized trials. So I think this is, prior studies showed what you did. And then that's why the NHA's base study, funded study, they looked at this. And for now, the strongest evidence for what we have. How, maybe something will change in the future, but this is the largest randomized trial addressing the issue, and it really showed no benefit or no difference.
Right, طيب يا نستشير كمان we are left with two talks about diabetes and diabetes also the kidney nephropathy. So why not we go on and then have the break at the end? Okay? Agree? Right. Okay, so our next speaker will be Dr. Salaf Ibrahim Abdelaziz. She will be talking about update on the management of diabetes mellitus.
يعني ما من الرعب. لا ما اوكي تمام.
بارك الله فيك. السلام عليكم دكتور فاتح، شرفتنا كثير. الله يخليك. الله يسلمك. الله يخليك.
عاش مشاهد، كيف امورك؟ كيف احوالك؟ كويسه 100%.
Okay, Dr. Salaf, yes.
السلام عليكم. السلام عليكم ورحمة الله تعالى وبركاته. بسم الله الرحمن الرحيم. In the next In the next coming 20 minutes, I'll be talking about updates in the management of type 2 diabetes. These are my disclosures, and I totally assure you that this talk has no connection to any pharmaceutical company or pharmaceutical medication, because I'm going to be talking about a lot of drugs. First, I'll be giving you an idea about the magnitude of the disease and how to approach a patient with diabetes. And I'll show you the available treatment options and a view or summary of the recent guidelines or what the recent guidelines suggest. The National Diabetes Statistics Report 2022, I'm sorry about these images up there, on the current prevalence of diabetes estimates that more than 130 million adults are living with diabetes or pre-diabetes in the United States. The IDF Diabetes Atlas 2019, accessed in 2021, estimated that the global diabetes population was 9.3% in 2019, and it is expected to increase to 10.2 in 2030 and 12.9 by 2045. And understandably, it's the urban areas that have higher prevalence than rural areas and high-income countries with more prevalence than low-income countries, with type 2 diabetes being the majority at 90%. According again to the IDF Diabetes Atlas, Sudan is reported among the countries with a prevalence of more than 12%. However, recently a community-based research from Sudan demonstrated relatively higher prevalence rates at 20.8% of the studied population, 10% were newly diagnosed, and 80% were uncontrolled. So you can just imagine the burden of the disease and the complications and what comes after that. Okay, generally in general medicine, what you really need to know to manage any form of disease is the same. You need a thorough background of the physiology and pathogenesis of the disease. Here we're talking about diabetes. You need to know as well the available medications out there in the market, availability, affordability, and how they work, the different kinetics of the medication, when and how they work. And of course, you need to know or have a background of the general guidelines and policies in your local hospitals. Just to remind you that type 2 diabetes is a chronic progressive disease with almost 50% of the beta cells of the pancreas not functioning at diagnosis. So just imagine that when you receive a patient, a newly diagnosed patient comes to you in the clinic who already is surviving with half of a pancreas. This is, I know it's bluntly put, but you have to think of this very carefully because this will guide you towards the management and what to do next. So, when many outcome studies have also helped us to know the natural history of the disease and when to intervene. There are two types of interventions here. We have preventive intervention and treatment intervention. So we can try to introduce the prevention intervention at this stage, and this is probably 6 to 10 years before diagnosis. The dotted or broken line is the line of diagnosis, and pre-diagnosis, before diagnosis, over the previous 10 years, some abnormality is going on in the body, abnormal glucose homeostasis, increase in insulin resistance, and deterioration in beta cell function. So it is already almost too late because after that, macrovascular and microvascular complications will intervene, and here you will have to start treatment. People have started thinking of going back to the pre-diabetes phase. We call it as pre-diabetes, trying to pick up who are those patients that are categorized as pre-diabetes and intervening early. There are a couple of studies that have been done. One is a landmark study done by the Swedish, and they have found that treating patients with, it's known as DPPO study, prevention study, that intensive intervention with lifestyle modification plus minus metformin in the pre-diabetes phase has managed to delay the onset of diabetes by almost 68% in the intervention lifestyle modification hand, whereas only 40% with those patients taking metformin. So this is to strictly put that or advocate that lifestyle modification is more and more important. However, on the treatment hand, on the other hand, treatment intervention, which to us will be too late, but still there is a chance of trying to improve the insulin resistance here and to improve beta cell function. Sometimes we say just to rest the pancreas, introduce medication, especially early insulinization, and thereby improving the blood glucose levels, and thereby reducing our macrovascular and microvascular complications. Available treatment options. You're all aware, just to remind you, of the famous and common biguanides in the market. Metformin has for quite a very long time and is still one of the most important first-line medications to treat type 2 diabetes. So every patient with type 2 diabetes should be on metformin unless contraindicated. Metformin is a very good drug, We all know the side effects of lactic acidosis. Initially, people were, in several years back, people were very hesitant on using it, but recently it has become the #1 drug in treatment of type 2 diabetes. Every patient should have it, as mentioned, unless contraindicated with severe heart failure or renal impairment, estimated GFR less than 30. We try to be very careful here. Sulfonylureas, again, these are one of the most famous medications. They've been out there in the market for several years. Examples, glibenclamide has been there for a very long time. Unfortunately, glibenclamide is famous for its long action and precipitating hypoglycemia, especially in the elderly. And it has gradually been, the use has been gradually, we're using it much less and less now. Glimepiride, gliclazide, liberide, all these are second and third generation sulfonylureas with different durations of action and less shorter action, making the incidence of hypoglycemia much less and better to, or easy to be controlled. Glinides, ripaclinides, and meticlinide, these are somewhat similar to sulfonylureas. They both stimulate the beta cells of the pancreas to produce insulin. And we have the TZDs, the pioglitazone, which also is a very popular and very good drug, and it works on insulin. It works on insulin sensitization and on insulin, increasing insulin secretion. Over the past decade or more, we have the incretin-based therapy, and the incretins, these are basically polypeptides that are produced from the GI tract, and they have been found to stimulate the beta cells of the pancreas to produce insulin and stimulate the alpha cells to produce glucagon or to inhibit glucagon. So, and this action basically starts in when the patient or person takes in glucose or carbohydrates. So we call this a glucose-dependent manner, which means that these incretins will not be working unless you are taking food. Examples are the GLP-1 agonists, the liraglutide, semaglutide. We were talking about those for obesity a while ago, early in the morning, exenatide and dulaglutide. And GLP-1 agonists, the only drawback is that they're injectable, and they are the good thing about them is they are once a week, but the other bad thing about them is that they are very expensive. DPP-4 inhibitors are also a form of incretin-based therapy. The GLP-1 agonists are broken down in the body by enzymes known as DPP-4. So by inhibiting these enzymes, we are providing more GLP-1 agonists in the system. And just to remind you that diabetics have less incretins in their body than non-diabetics. So that's the aim or the goal is to increase the incretin within the patient or diabetic patient's body. So examples in I'm sure you're familiar with the vildagliptins, sagliptin, linagliptin. So they all end in leptin, gliptin, and those end in glutide. So just to make things easy. Next, and one of the most recent medications or the revolution of the SGLT2 inhibitors. Examples are, they have been alluded to by Dr. Ahmed Ali, dapagliflozin, Cana, and EMPA. They are oral medication. Just to go back to DPP-4 inhibitors, they are also oral, taken orally. SGLT2 inhibitors basically work at the level of the kidneys, inhibiting the enzyme SGLT2, which is in charge of reabsorbing the glucose, and so you get loss of glucose in the urine. Professor Fadel, inshallah, will be talking, in the next talk, will be talking more about the SGLT2 inhibitors. We come now to insulin. Insulin analogs out there, the most famous insulins are the soluble insulin and the mixed insulin. Now in the market we have the insulin analogs. There are different types of insulins with different modes of action, and the most recent are the basal insulin, okay? Most recently, maybe 10, 15 years back. The basal insulins are one of the best medications so far to treat type 1 and type 2 diabetes, and type 2 when needed. Basal insulin is basically the level or the amount of insulin that is available within the body over whatever the person's state is, whether you're fasting, you've eaten, you haven't eaten, you've drinking some coffee or just tea. There is within everybody's body, any non-diabetic, there is a level of basal insulin already available. In diabetics, however, this basal insulin level is much less than non-diabetics. This basal insulin is responsible for the glucose homeostasis in the body. So the best option is to put your patients on basal insulin to mimic the normal physiology and give the patient boluses of regular or soluble insulin immediately before the meals. This is done with type 1. This is known as basal bolus regimens. However, in type 2 diabetes, you can give your patients basal insulin with any form or combination of oral antidiabetic agents. This is just a table summarizing what I've just said, how the different actions of the medication. Okay, let's see what the American Diabetes Association has presented to us. In 2017, the ADA presented the long-term trends in anti-diabetes agents usage in the US. This is real-world evidence in patients newly diagnosed with type 2. The first part of the chart is the proportion of first anti-diabetic agents started by year of initiation. You can note the green columns here represent metformin, and as you can see, the use of metformin as first-line drug in 2005 has increased from 60 to 77%. So it is widely used and still when maintaining and increasing. Of note is the use of sulfonylureas as first-line medication is dropping. Insulin, however, seems to be maintaining the more or less the same level. The second part, or the second chart, shows the proportion of add-on medication, the second anti-diabetes drugs by year of initiation. Metformin is already there. Add-on medication, the navy blue columns represent sulfonylureas, and as second add-on, sulfonylureas tend to have a decrease in the trend from 60 to 46%, but despite that, they still remain very popular second add-on drugs. Of note, DPP-4 inhibitors have increased from 6 to 20%, and as well as insulin as second add-on from 7 to 17%. And this is really very nice because early insulinization is really a very, very important point in treating a diabetic patient. So this shows that really people are moving more towards early insulinization. The use of SGLT2 inhibitors here is also increasing. There's a trend from 2014 to 16 of 3 to 7%. Okay. Just of note is that almost all diabetes therapies are associated, or most of them are associated with weight gain. And weight gain is an enemy for us, because with weight gain, you get insulin resistance, and we don't want the insulin resistance. And we always advise our diabetic patients to lose weight. So, and metformin, as you can see here, causes weight loss, and they don't like it. We're always quarreling and arguing with our diabetes patients, and especially the ladies, because they say, we lost weight on metformin, I don't like it, ما نفع معاي، عمل لي نزل لي وزني وشوفي صحتي. تقولي انت حاسه كده كويسه، احنا دايرين لك as a diabetic تبكي كده. لكن في certain views, they want to remain, زي ما we discussed, overweight. Sulfonylurea is well known. They increase weight, glenites, TZDs, and insulin, of course. DPP-4 inhibitors are weight neutral. This is a positive thing, And the good thing about them is they're used during fasting, during Ramadan, because they tend not to cause hypoglycemia. I'll be talking about those medications causing hypoglycemia as well. GLP-1 agonists, these are the medications that have revolutionized the obesity world and are famous for their weight loss. In addition to weight loss, there is hypoglycemia. Then when we look into a diabetes medication, we focus on weight loss and hypoglycemia. Sulfonylureas, as you all know, are famous for causing hypoglycemia. Glinides, to some extent, because they work basically the same way. TZDs they don't tend to cause hypoglycemia as the sulfonylureas. Insulin, of course, you're all aware. Understandably, it can cause hypoglycemia, different stages of hypoglycemia, especially if the patient is not well orientated to how to take it and when to eat and all these things. Metformin, the good thing about it, does not cause hypoglycemia. And GLP-1 receptor agonists, likewise, that is why they are also used, they can be used in non-diabetic patients. Regarding the basal insulin, Lantus, Glargine, etc., they are also known not to cause hypoglycemia. Controlling multiple parameters is essential and effective for the treatment of patients with type 2 diabetes. Like, when we look at the patient, basically it's a holistic view. We look at the patient with a holistic view. So we tend to look at the hemoglobin A1C, the weight, the blood pressure, lipids, and smoking, because all these things are associated with atherosclerosis and increased cardiorenal and cardiovascular events. The most important thing, and the very first thing to do when you're managing a patient with diabetes, is to assess the patient's targets, because all patients are not alike. You need to individualize your medication, assess each patient's level of fasting blood glucose to our postprandial and hemoglobin A1C target, as well as advocating weight loss to a certain target, blood pressure control, lipid control, and to quit smoking. You need a multidisciplinary team as well, because the holistic approach also it includes cardiovascular, cardiologists, nephrologists, and even gastroenterologists when your patient starts to get the autonomic gastropathies, etc. And in addition, the most importantly, dietitians, nutritionalists, therapeutic nutritionists, and podiatrists, and diabetes nurse educators. So this is really a big team. If you get into one clinic, as many of those as you can, and then refer the rest, that would be a great idea. And not to forget the eye clinic. Retinal screening is a very important stage in diabetes management. We talked about the cardiovascular and atherosclerotic risk assessment and the holistic approach and patient-centered approach. This is the guide to the 2022 changes in the ADA standards of care, published in October 22 in the Diabetes Care. And the American Association, the American Diabetes Association, put forth a consensus report on the management of diabetes, especially type 2 diabetes. And the first part of the report is the decision cycle for a patient or person-centered approach. And this cycle, as you can see, though in clockwise, includes 7 categories or stations, and each category accesses the key points in diabetes management. Assessing, initially, on number 1, to assess the key person characteristics. You need to know the individual's priorities. You need to include the patient in decision making. You need to know the patient's current lifestyle and health behaviors, the comorbidities. That is basically taking a good history from the patient. And you need to also include the issues such as motivation, depression, and cognition. The second category is considering specific factors that impact your choice of treatment. The individual's glycemic and weight goals, the impact on weight, hypoglycemia, cardiorenal protection, underlying physiological factors. The side effect profiles of medication are very important. That is the weight gain, the weight loss or weight neutrality, and the hypoglycemia. The complexity of the regimen and the choice of the patient to minimize the, optimize the medication according to his acceptance or to results. Accessibility, cost, availability, and durability of the drugs are very important. The third category talks about utilizing shared decision-making to create a management plan. This is very important because if your patient is not involved, he or she will not be compliant. So the main goal is setting shared decision-making. The fourth category is agreeing on management plan. It should be specific, measurable, achievable, realistic, and time-limited, understandably. Implementation management, ensuring regular review of the patient. This also helps in reducing the patient inertia or even physician inertia. If you see the patient very frequently, every 2 to 3 months, or sorry, every 2 to 3 months, initially more frequent, then this reduces the tendency to inertia. Provide ongoing support and monitoring, emotional well-being, lifestyle and health behaviors, tolerability of medication, checking the continuous glucose monitoring and blood glucose monitoring to know where the patient is, follow-up of the hemoglobin A1C, and weight and blood pressure and other parameters we talked about. The last category is review and agree on management plan. Of course, any management plan you put forth, you need to evaluate it. You review, evaluate, and change as needed. Okay, the second part of the report is the use of the glucose-lowering medications in the management of type 2 diabetes. Of course, basically, on the background is healthy lifestyle behaviors. Any patient with diabetes, number one is lifestyle changes, monitoring, diabetes self-management, education and support, and the social determinants of health. I'm not sure if this is clear, but this is what we talked about. And then you start metformin. These are the two basic things when you first see a newly diagnosed patient. Or even if he's not newly diagnosed, you need to make sure that these are already available. The goals here, if you notice that the slide is divided into two goals, I'm very sorry for these busy slides, but I need to use them because they're basically, these are what the guidelines say. This side is the cardiorenal and cardiovascular protection, and on the other side is the glycemic control and weight control. Right. Patients with atherosclerotic cardiovascular disease or renal disease, they recommend to use GLP-1 or to add GLP-1 receptor agonist with proven cardiovascular benefit, either or an SGLT2 inhibitor with proven cardiovascular benefit. And if you continue still hemoglobin A1C is above target, you add them both. So first step, you can add either one, and then you can add both. In cases of heart failure, I'm sure Dr. Medali said more than enough on that. They recommend SGLT2 inhibitors. Renal failure, CKD, my father will talk to us about this. I won't go into further details. On the other side is the goal achieving a maintenance of glycemic control. And this initially, as I mentioned earlier, you have to put your targets for the patient. Target for hemoglobin A1C. Yani a patient who was newly diagnosed, is young, duration, newly diagnosed, you don't aim at the target of a hemoglobin A1C as same as a patient who has had diabetes for over 10 years with comorbidities. Yani if the normal hemoglobin A1C is less than 6.5%, such a patient with comorbidities and frequent hypoglycemias, according to his lifestyle, how far or how much the patient can do, I aim at a hemoglobin A1C more higher than this. 8 would be reasonable, because the tighter I go, the more incidence of hypoglycemia I have and the more harm I'll be doing this patient. So it is very important to decide your target hemoglobin A1C, the fasting and 12 postprandial for every individual patient alone, and then you work on trying to get to those targets. Avoid inertia, try and go towards early insulinization. About insulin is recommended any patient hemoglobin A1C above 9, we immediately start insulin. of course, lifestyle modification, metformin plus insulin, and then you monitor the patient based on insulin. One of the best, as I mentioned earlier, you monitor the patient's, based on insulin, we monitor usually the fasting blood glucose until we put the patient within the target, then we start monitoring the 2-hour postprandial until the patient is within target. Difficulty in achieving target, we add on to metformin, sulfonylureas, or DPP-4 inhibitors. Especially DPP-4 inhibitors are used when the postprandial blood glucose or blood sugars are high. Regarding obesity, weight management, which has been the GLP-1 agonists are out there in the market for this. Unfortunately, as was previously mentioned, all these medications are costly, but we'll try and do our best. Right. Just to mention, I have a couple of slides on recommendations for blood glucose lowering when metformin is contraindicated. We might come across such a case, and if this patient is symptomatic, hyperglycemia, consider insulin or sulfonylurea, and metformin, when metformin is contraindicated, dual therapy with DPP-4 inhibitors and pioglitazone. Pioglitazone is quite a popular drug for reducing insulin resistance. So it can be used, DPP-4 inhibitors or sulfonylurea or pioglitazone and a sulfonylurea. So we have many choices out there. Cost, we talked about cost. First line, metformin monotherapy. If you need intensification, you can add sulfonylureas. Later generation, add a TZD, and add a third intensification, add a basal insulin. These drugs are relatively available, affordable. Again, I insist, basal insulin can come first line if hemoglobin A1C is more than 9. Cardiovascular risk categories, I won't go over these. This is, you've already seen that, and the medications that are advocated for those. Lipid lowering is very, very important. The lipid profile. In patients with diabetes with very high cardiovascular risk, the target LDL is less than 55. احنا بنشوف نطلب الليبid profile بنلقى انه خدين لنا a range. These range are laboratory ranges. We don't work with those ranges. Okay? According to the guidelines and which risk category you put your patient, you aim to put him there. If the patient with diabetes, high cardiovascular risk, your target is less than 70, and moderate cardiovascular risk target less than 100. So we have to be very careful. But then a lipid profile, it does not necessarily need to be fasting unless you are clearly looking into the triglyceride. Okay? Peripheral vascular disease, these are the two medications that have been found, SGLT2 inhibitors, empagliflozin, gamma, and DAPA, as well as GLP-1 receptor agonists. Okay, so our key take-home points. Remember to have a patient-centered, holistic approach, individualize your treatment, teamwork, consider medication availability and affordability, avoid treatment inertia, early insulinization and early intensification of medication, balance the benefits and potential harms of treatment in the context of comorbidities, in the context of complications, hypoglycemia, and weight gain. This is my final slide. This is really a very interesting slide. This is about أسطورة ولا خرافات إقليمية. قالوا في واحد اسمه Procrustes, he was a roach smith or a bandit. Smith اللي هو زي locksmith بنت حداد. قام عمل له an iron bed. قام هو بيخطف الناس ومجرم. He attacks people, puts him onto this bed. If they're short in the bed, he stretches them and pins them on the bed. If they're too long for the bed, he cuts off their legs. So, if the bed represents, his iron bed represents our guidelines, don't try to squeeze your patient into the bed, but try to modify and make the bed suitable to fit this patient. Thank you very much.
Thank you very much, Dr. Salam. You made it rather easier and difficult. You see? It's not easy, and the cost comes also. You know, these gliptins, if you take the gliflozin, again gliflozin, with metformin is very expensive. Very expensive. 25 مليون واحد من المرضى قال احسن لي السكري بتاعي وادويتي القديمه ذاتها وهي Right. I think the next speaker, Professor Fadl, will tell us about a problem of diabetes itself, which can make a lot of morbidity for patients. That is a kidney problem, topped by nephropathy. Diabetic nephropathy is a big problem again. Right.
السلام عليكم كلكم. The speaker can make life easy for me. Kevin, talk here is a team work of my colleagues and friends in nephrology. وفي النهاية لخصتها وخديتها الاسبازول اللي قدمها في اللاست nephrology society meeting on the 13th of January. وهي شوية update عن الدايابيتيك نيفروباثي. Diabetes as you see, as you can see, the common disease. أنا هتكلم لغاية ما نصلح تاني. وفي أرقام كثيرة جدا موجودة. بشوف الريموفر أفتح الكمبيوتر وأفتح ما حأشوفكم كثير. طيب. المفروض تكون في الكمبيوتر وبعدين تجد هو ده. أنا دائما هي الفكره كلها.
We are sorry, just there's a problem with
معلش.
the flash.
الفكره انه diabetes is a common disease. Diabetic nephropathy affects 40% of people with diabetes. Okay? وdiabetes type 1 يعني النفروباثي بيحصل from the word go. once انه البيشنت حصلتها type 1 diabetes بيحصل hyperfiltration. والفكره كلها يعني مبنيه على الثيوري of hyperfiltration ونفرون لوس. طيب. انا الحين ده اديكم الحاجه الاخيره اللي حصلت في العالم الستاديز اللي اتعملت كلها 3 ميجا ستاديز على الصوديوم جلوكوز كو ترانسبورت انهبيترز وكلهم terminated before the end because they showed remarkable results و evidence based يعني facts. طيب الادويه دي الفلوزين دي اللي هي دابا الفلوزين والجامبروفلوزين كلها اكتشفت من الساق بتاع شجره التفاح. وبعدين مشت الحكايه لغايه اخر حاجه بقت ادويه وبقت حاجه في الجايد لاين evidence based A after يعني standard of care treatment when you control diabetes with weight, exercise, diet and all the medications. لكن كل الناس اللي عندهم diabetic kidney disease short of people as contraindication أو الحاجات اللي ما فيها evidence based now people on dialysis, transplant patients, GFR below 20 or other polycystic kidney disease. طبعا برضه في حاجات كانت contraindication لأن الأدوية دي كلها بتعمل شنو؟ تمنع الابزوربشن في البروكسيمال تيوبيولز وبالتالي البول حيكون مليان صوديوم وجلوكوز ولذلك بيحصل رطب انفكشن رينال انفكشن بالذات في الفيميلز. ولو في ناس عندهم repeated renal infections it's not recommended to be used in them. Definitely it's not indicated in type 1 diabetes or insulin dependent diabetes. الاستاديز اللي ماشي على الترانسبلانت والبوليسيستيك كدني والبيبول اون داياليسيس لكن دي لسه ما بروفن. في 3 مين ستاديز كلها terminated before the end because they showed remarkable improvement more than 30 to 35% improvement. كنت كلامي لك شك عليك. انا الحقيقه يعني ذا كريدت شود جو تو دكتور وليد هو قدم البيبر دي ونحن استفدنا منها كلنا ولخصنا الموضوع ده لكم. دكتور وليد used to be a teaching assistant in our department now he's a consultant in Saudi Arabia. When I talk to him hopefully he will come back. يلا صار next. طيب يعني الكونسلاف ولا other speakers يعني already talked about diabetes والcontrol of diabetes والmagnitude. يعني كل سنة عدد الدايابيتس في العالم بيزيد والprojected figures are alarming really alarming. وحتى نحن هنا في السودان لسه بنشوف رصد diabetes لكن unfortunately الدايابيتس كير قليل لأنه الدايابيتس يا جماعة is a multidisciplinary approach management. يعني الفيزيشن النفرولوجيست النيرس الاوفثالمولوجي. يعني انا بشوف عيانين كثيرين جدا في حياته يعني عنده سكر 40 سنه ما مشى شافوا العيون بتاعته. ودايابيتس is the commonest cause of blindness in the world with the commonest cause of renal failure in the world. ما ممكن ممكن جدا. اوكي طيب شكرا لك. وانت في مانع نبدا طيب اوكي هنا بس يعني just one case presentation 67 years old woman with hypertension and type 2 diabetes was hospitalized for 2 times over the past year with decompensated heart failure. She's on furosemide, metoprolol, lisinopril and metformin. Seen a renal clinic for follow-up. She had an occasional shortness of breath. Her blood pressure was 138/70, clear lungs, mild lower lymphedema. Her GFR is 33, and her potassium is 5.1, and her urine albumin creatinine ratio 76 milligram per millimole, our hemoglobin A1C is 6.8. طيب انا هفسخ من الحكايه. طيب وش ثاني؟ طيب احنا دايرين بس نرسل رساله انه يا جماعه احنا تريتمنت ابديت. صوديوم جلوكوز كو ترانسبورتر انهبيتور ده a must in diabetic nephropathy. جلوكوجون بيبتايد ريسبتور اجونست ثلاثي بيشن ده. الحاجه اللي انا داير اركز عليها المينالوكورتيكويد ريسبتور انتاجونست، ودول اللي هم اللاكتون وفينولون وفينولون، ثلاثه ادويه. الاثنين الاولانيات هم نون ستيرويدال مينالوكورتيكويد ريسبتور انتاجونست، لكن they cause hyperkalemia. والهايبركاليميا مشكله. الجديده الفينولون دي نون ستيرويدال مينالوكورتيكويد ريسبتور انتاجونست which does not cause hyperkalemia. في مجهود كبير انه يخش السودان شويه لانه الاثنين الباقيين الدكتون والفينولون موجودين. هنا شلون؟ طيب. Diabetic kidney disease is a complex and prevalent disease with numerous overlapping etiologic pathways. Most patients succumb to cardiovascular events and death rather than reach end-stage kidney disease. الديابيتس بيقتل الناس قبل ما يحصلوا الفشل الكلوي النهائي. Emerging treatments have transformed the landscape, offering new options and new hope. طيب دي أرقام. Now, there are about 537 million others living with it in 2021. Predicted are 643 million people by the year 2030. More than 3 in 4 others live in low and middle income countries. The cost is about 966 billion in health expenditure. طيب, the kidney is the major victim of diabetes. Diabetic kidney disease develops in more than 30% of diabetic patients and is the leading cause of chronic kidney disease in the world. A driver of diabetic kidney disease is inflammation. يعني انت عندك hemodynamic dysregulation, hyperglycemia, all culminate into inflammation and chronic kidney disease. اللي يشوفوه. طيب ماشي. Global burden of diabetic kidney disease, a treatment update is SGLT1 inhibitor, GLP1 receptor agonist, mineralocorticoid receptor antagonist. دي هسه بقت must في الدايابيتك كدني ديزيز. مش evidence based وهوريكم الاستاديز. طيب دي دقيقة بس. دي سلايد بتوري انه في 1835 اكتشف الفلوريزين isolated from the apple tree bark. In 1886 glucosuric properties were discovered. In 1987 glucosuria identified from fluorescein inhibition of glucose the absorption by the renal tubules. يعني ده اكتشفوه في النبات وبعد ذلك بقى دواء. In 1990 the first orally absorbed SGLT2 developed بقت حبوب. وهم طبعا عندهم اكسس كثيره جدا، يا ريت لو كانت الظاهره كان وريتكم اياها، لكن هم بيشتغلوا في البروكسيمال تيوبيولز وبالتالي بيمنعوا الابزوربشن اوف الصوديوم والجلوكوز which appear in urine. لكن طبعا عندهم a lot of other functions اللي هم they decrease the intraglomerular pressure, they have an effect on the heart, they have an effect on the kidneys, they have an effect on the brain. كل السيستم دي هم بيأثروا عليها لانه انتوا عارفين حاجتين مهمات في جسم الانسان، الصوديوم والسكر. فهم بيتعاملوا مع الحكايه دي. طيب. Three studies were done. واحدة اسمها جريدرز فيها 4401 مريض diabetic type 2 estimated GFR 30 to 90. الستادي دي terminated before the end لأنه الريزلتس كانت outstanding. Next. Another دراسة برضو DAPA chronic kidney disease برضو فيها حوالي 4304 مريض with the GFR criteria GFR more than 25 و less than 75, urine albumin ratio about more than 200, less than 5,000, with or without diabetes, dapagliflozin, it was also terminated before the end because it showed remarkable results. يعني الامبا كدني برضه نفس الشيء terminated before the end, and they all conclusion انه these drugs are essential and should be in the package of management of diabetic kidney disease, and they have a positive effect on the heart, which has been mentioned before.
الكونترا-انديكيشنز شنو قلت يا
الكونترا-انديكيشن so far انه GFR below 20 في الكدني, polycystic kidneys, transplant patients, people on dialysis. طبعا في الأذر diabetic ketoacidosis, type 1 diabetes, uncontrolled urinary tract infection. اوكي؟ طيب هم في الأول بيعملوا دب في الجي اف ار زي اللي تتذكروا لما الرينا جلوتين سيستم كانوا بيعملوا ديكريس في الرينال فانكشن والسيرم كرياتين بيزيد ما تشفى. دي حاجه نوت كونسيرنينج لانه بعد طوالي بيحصل لي وبيحصل طوالي تحسن في وظيفه الكليه. حتى البلاسيبو تريتمنت جربت ويل كنترول بلاسيبو يعني تعمل ريزلت ستدي وورت انه الدب دي از نوت اوف كونسيرن. لكن في الفيرست 4 ويكس طبعا بعد ذلك لو مشت اكثر من 4 ويكس you have to be careful. في الريست اوف اي طبعا in all the others with type 2 diabetes you have to be careful about that انه البيشنت يكون well hydrated ما هايبوفوليميك لانه طبعا هم they remove all the sodium and glucose in the urine. The small dip in estimated GFR is followed by one big leap for kidney protection. leap يعني قفزة. Diabetic kidney disease summary is a leading cause of morbidity and mortality with enormous health and economic implications. Based on randomized controlled trials, SGLT2 inhibitors are now established cardiorenal protective drugs with multiple putative mechanisms. They slow the progression of diabetic kidney disease across a wide range of GFR and glomerular. Although can cause an initial GFR dip, they seem to be protective from acute kidney injury. هو يعني هو يعني ناس نديهم الادويه اللي هو type 2 diabetes chronic kidney disease with an estimated GFR more than 20 or cardiovascular disease with heart failure, maybe in the future in the transplant patients, not yet in type 1 diabetes, not yet in end stage of dialysis, not yet in LPKD اللي هو autosomal dominant kidney polycystic kidney disease, not in SLE, not in vasculitis, perhaps in people with recurrent urinary tract infection with type 2 diabetes for concern of diabetic ketosis. من الكورتيكويد ده بس نقول عنهم كلمتين. طبعا الدي ال بي 1 قلتيهم لكن امشي فيهم. في سلايد كده فيها الدي ال بي ده بيشتغلوا في اي حاجه صح يا شباب؟ الهارت، الستمك، البرين بيشتغلوا في الحاجات كلها عشان كده هم ادويه ممتازين جدا وادويه كويسه should not be patients should not be deprived of them. امشي تاني. هذا نطول عليهم. طيب GLP-1 receptor agonists are emerging promising real protective agents with glomerular hemodynamics, anti-inflammatory, anti-fibrotic properties. The flow study first indicated GLP-1A agonist renal outcomes. It also proved that these drugs are good and it is evidence-based that they have a good impact on the kidney function and they arrest the progression of chronic kidney disease. The third drug, category of drug is the mineralocorticoid receptor antagonist, which they have an action on the brain, especially the sympathetic nervous system. They have an action on the blood vessel. These are the mineralocorticoid drugs, aldactone, spironolactone, finerenone, and finerenone. They have action on the brain, on the blood vessel, on the heart, and on the kidney. On the kidney, they decrease potassium, they increase sodium and water retention, they can cause proteinuria, they can cause glomerular injury, and they can lead to hypertension, heart failure, and chronic kidney disease. These aldosterone, like the agonist, الدسترون اجونست بيعملوا الحاجات دي. لما تدي انتي الدسترون بتوقف الحاجات دي، لكن بيعملوا الاثنين الاوائل انهم بيعملوا هايبركاليميا، ودي مشكله كونسيرن. عشان كده جاء الدواء الجديد دي الفينولون اللي هو ده ما بيعمل هايبركاليميا، لانه طيب الميلانوكورتيكويد ريسبتور انتاجونست والستيرويد الميلانوكورتيكويد اجونست cardiovascular outcomes, proven benefit, renal outcomes, significant reduction of albuminuria with consistent hyperkalemia, leading to discontinuation of therapy in some CKD patients, which lead to novel non-steroidal melanocorticoid antagonist finerenone. ده دواء جديد طبعا وما بيعمل hyperkalemia. وعنده يعني effect on the outcome of kidney function and heart. في نفس الوقت ما بيعمل هايبركاليميا، ما بيعمل sexual side effects like gynecomastia. الهايف لايف بتاعته 2 to 3 hours. It has less CNS penetration. It is selective to melanocorticoid. Take home message. American therapies show great promise for substantially reducing the burden of diabetic kidney disease, kidney failure, heart failure, atherosclerotic cardiovascular disease, and death. Nephrologists should take the lead in dissemination, safe and effective utilization of medications along with other involved specialists. Knowledge gaps, role of medication in a specific population, advanced diabetic kidney disease, normal albuminuria, transplant patients. Combining new therapies is a personalized manner. The killing of polypharmacy. يا جماعة لو لاحظتوا من قبل يعني لو في مريض واحد أخذ الأدوية دي كلها اللي هو جاري. فدي مشكلة، لكن طبعا كان في قبل فترة من الزمن الاختراع بتاع السوبر بيل، إنه كل الأدوية دي الأسبرين والبيتا بلوكرز وكلها تكون في بيل واحدة. الشركات رفضت. قالت ما هو ممكن. فما بيجيب لها فلوس. في ongoing trials for renal lifestyle, DAPA, hemodialysis, اللي قلناهم. في ترايل لسه على الترانسبلانت بيشنتس، على الناس الهيمودياليسيس، على الناس اللي جي اف ار ديفلوبمنت. بس. Thank you very much.
Thank you very much, Professor Fadel. Yeah, okay, you just made a good account. It's all right, yeah, I think. Right, I think we are left with just short presentation from Azad company, and then Professor Omar Zaid, we welcome you alone. Professor Omar Zaid is the president of the Sudan Association of Physicians. And as you know, the conference of Sudan Association of Physicians is going to take place in March, is it? Yeah. Would you just give us an overview of the election?
Ahmed.
تفتكر زهجوا ولا ما زهجوا؟ زهجوا؟ مش أقول لهم كلام لذيذ كده. personality بس حكيف. كتير.
لكن ممتاز. very high power.
يفتكر كده.
It's a shame إنه ما يكون مع ناس كثيرة أو يكون في documentation.
هي غايته حاسة ده بيعمل في documentation. ما عارفة عن شيء.
السلام عليكم يا شباب، كويسين؟ أنا والله تكلمت معكم، استشرت الدكتور محمد علي، قلت لي بس ما داير الناس تكون أخذت علم كثير يعني ويحسوا الحكاية is too much.
اوفردوز.
يعني بفتكر أنا بس داير أقول لكم كل واحد في الحياة دي عنده رسالة، وكل واحد فيكم is great on his own. كويس؟ و everyone has a story. كويس؟ حتى شوفوا قيمة الستوريز اللي احنا سمعناها دي. كويس؟ though الكور واحد. الكور كان بيجا sorrow, كان بيجا pain, كان بيجا despair, كان بيجا happiness. It is the same. لكن كل واحد بيوري his story in his own way. مش كده؟ مثلا كلنا عندنا feelings. Through our personality، لأن كل واحد عنده personality مختلفة، you show that feeling في المجال حقك ده. كان بقى asthma، كان بقى diabetes، كان بقى way of life كده. فأنا بقول إنكم تقعدوا تسستين، يعني ممكن تمشوا ببال يعني. لكن لو لاحظتوا كل زول ادانا a different flavor، صح؟ وطريقة وقوفه، طريقة كلامه كده. بعدين تلاحظوا البروفيل الفاضل ده الطشة الكلام طشة، صح؟ لكن he was really لأنه he's a Kitchener holder طبعا. يعني he was able يعني دخل. أنا ذاتي فهمت منه المينرال كورتيكويد والكلام ده. فأنا داير أقول لكم الليلة we had a great day بوجودكم، وأنا I wish إنتوا ذاتكم you had real science, real medicine. وتعلمنا حاجات كثيرة translational medicine. تعلمنا من بشرى، من أحمد، من سلاف، من بروفيل باقر. بروفيل باقر ده واقف في الكلام ده لو حسه يعني how much دي كلها creativity. هو اللي اقترح نعمل حاجة زي كده. وطبعا أوشيك أبدعنا بكلامه اللي بيقوله ده. فده أقول لكم سعيدين بكم، ومن الكلام ده you can learn for your life، ما بس for the day. أوكي؟ عشان الحكاية دي تخلينا شوية positive.
كده هسه ريفرشت صدقيني كده ريفرشت هسه
عليك الرسمة. بروف عمر أنت هتتكلم صح؟
لا بس كان فرصة يكون أبديت في فالسيس وفي
عليك الله يا بروف عمر، بس قول لنا حاجة.
لا نتكلم حاجة بس عن المؤتمر.
لا خلاص جدا، لا تعال قدام، النبي خليه يجي قدام. يا بروف عمر تفضل. طلع يا اخواننا بروف عمر زايد.
Okay, Professor Omar Zaid will give you an overview about the conference of Sudan Association of Physicians.
السلام عليكم.
وعليكم السلام.
أنا صاحب ما حكون برزنتيشن، لكن أنا أتحدث يعني بصفتي أنا at this time رئيس الجمعية الاختصاصية الطب الباطني السوداني. وهي طبعا الشباب اللي حينضموا في المستقبل ده هي جمعية تضم كل التخصصات يعني. في النهاية هي الجمعية الأم كما يسمونها، وعضويتها كل الأطباء المتخصصين بعمل التخصص الأولى في الطب الباطني. ودائما الاكزيكتيف كوميتي ديفرنت، يعني هسه الاكزيكتيف كوميتي حق الجمعية الراني فوق كل السبيشاليتيز. يعني عندنا من الكارديولوجي عندنا دكتور انيس، من الدكتورولوجي عندنا دكتور سلاف، عندنا من النيورولوجي دكتور اعتدال. يعني حتى الرئاسه حقت المؤتمر ما بترتبط بسبيشاليتي واحد عامل، والرؤساء السابقين كانوا من كل التخصصات. يعني عشان كده هي الجمعيه الام، لدرجه انها تعمل المؤتمر بتاعها كل سنتين. وزين السنتين دي كان من الجمعيات حاجه بيسموها البريزيدنت إلكت، يعني في نهايه المؤتمر بيختاروا الرئيس ويختاروا حاجه اسمها البريزيدنت إلكت. اللي اوتوماتيكلي بعد سنتين بيبقى الرئيس. بس للاسف الشديد انه انا في السنه بعد ما زلت 5 سنوات رئيس مقطوع الجناح، يعني مما بدا الكورونا، بدات الكورونا لحد هسه ديستربنس حصل في كل الافينيوز اوف لايف، في كل الافينيوز. فعشان كده الخدمات الطبيه تاثرت، النشاط الطبي تاثر، المؤتمرات تاثرت. فنحن في بصدد قيام المؤتمر حقنا الدعايه اللي هو يعني انه من يوم 11 ل 13 مارس حيكون في قاعة الصداقة. طبعا لما يكون قاعة الصداقة معناها فيها lot of course، فيها lot of activities وفيها lot of people collecting money collecting things، يعني حاجة. ودائما بنستقطب دائما a lot of students عشان يديروا المؤتمر، يتعلموا كيف إدارة المؤتمر ويكونوا ساعدين في التسجيلات. دي الهابت حقتنا. دائما كنا يعني بنكون انكلايند للكليه، يعني قلنا في انه سيلكتنج اور ستودنتس. فنحن اوريدي طلعنا كول اوف ابستراكتس، كول اوف ابستراكت فور different types or different specialties in medicine، وحددنا الزمن. لكن طلعنا كول اوف ابستراكت ثاني للستودنت. يعني الستودنت عندنا برنامج معين للستودنت حيكون فوقه كول اوف ابستراكت، لكن كل الستودنت بتاعنا الطب في السودان يعني كليات الطب حتى احنا وجهنا انه يمشي يجتمعوا بالروابط ويدوا معلومه للروابط. وبعدين عندنا جوائز قيمه شديد او برايز للبرنامج او للريسيرش اللي بيتعمل وبريزنتد باي الستودنت. وعندنا يعني جائزه للكونتنت وجائزه للويب برزنتيشن. وعشان كده بنحمسكم انه الناس بالذات ناس خامسه وناس العمل البروجكت قبل كده يقدموها في سكرين، وبعد ذاك البرزنتيشن الفايز والبرزنتر بتاع البرزنتيشن حتى في المؤتمر. ونامل انه المشاركه من الجميع، ونامل انه يكون مؤتمر ناجح ان شاء الله من 11 لحد 13 مارس ان شاء الله. شكرا جزيلا. يعني ظهرت هي في الفيسبوك طبعا، في الفيسبوك ممكن تتلاقي. وانا يعني حفزت المسؤولين اللي معانا ان يتصلوا بالروابط بتاعت الطب عشان ينشروها بين الطلاب. والكول حتكون 2. الكول الاول الفوق تلك جميع السبيشاليتيز المختلفه وكده. وعندنا الفهم حقه towards the higher quality health care من اجل الاشتغال بالرعايه الصحيه. لانه بالحاجه اللي حصلت وبالكورونا وبالاشياء اللي حصلت، فدفنتلي الشعار بتاعنا هو الكول فور اشتراك. وعندنا كول فور اشتراك للستودنت، الفاليبل برايز فور ذا بيست ستودنت او اشتراك. اوريدي يتوزع في كليات الطب المختلفه، ونعمل المشاركه والتحفيز للطلاب ولابناء الطلاب للنجاح فيها ان شاء الله. شكرا جزيلا.
لا اقعد معانا حبه يا بروف.
الميتنج
بس حنجيف هسه شويه عندنا الامتحانات.
ايوه النتيجه
هسه كان نادينك للامتحانات بتجي ان شاء الله.
بيجي لغايه بيجي يوم
خلاص تمام.
يوم.
يا سلام، ما قبضنا منك يوم، دي حاجه كويسه شديد. هسه كان بيتكلم عن دكتور محمد علي، قال قريت لو ناديناك تدينا حاجه عن ملاريا at some point بعد ما يخلص الميتنج تكون شويه فاضي.
خلاص ممكن.
خلاص تمام. السلام عليكم. كله بيت. كله بفضلك. عايزة انت التليفونات كان نفسي اشكره على الكلمة مش انه بس اشكر تمنيني
يعني
جاب لنا أزال جد ما عرفت
we end up our symposium by the closing talk from Azal. They generously sponsored this meeting. We thank them all for this. Some refreshment and breakfast outside. In just 10 minutes, Dr. Isa will tell us something about Azal products. Thank you.
طيب السلام عليكم. ان شاء الله حكون مختصر جدا على اساس الناس اخذت كفايتها من الانفورميشن ان شاء الله. في ازال نحن ماشيين مرحله جديده، المرحله دي الهدف بتاعها انه يكون في شراكه حقيقيه بين الجمعيات كلها مع بعض وبين ازال، بين الميديكال الميديسين عموما وبين ازال ان شاء الله. بدينا في الحاجه دي بالسبونسرنج للجمعيه ان شاء الله. احنا دائما سبونسرنج للمؤتمر بتاع الجمعيه بتاعت الطب الباطن، ودائما سبونسرنج للمؤتمر بتاع الكارديو، وسبونسرنج برضه للمؤتمر بتاعت الجمعيه بتاعت ضغط الدم. فدي كانت بدايه بالنسبه لنا احنا في ازال. باختصار ازال هو مصنع محلي هنا في السودان، هو عباره عن شراكه سعوديه يمنيه في بحر هنا في السودان. بدا في 2011 كان الفيرست لونشينج لاول برودكت في ازال. الحاجه اللي بتميز ازال انه هو شغال بالكرنت جود مانيفاكتشرنج براكتس. الفرق شنو بين الكرنت جود مانيفاكتشرنج براكتس والجود مانيفاكتشرنج براكتس؟ اي مصنع عشان يبدا المانيفاكتشرنج لازم يكون عنده الشهاده بتاعت الجود مانيفاكتشرنج براكتس. الكرنت هي ريكويرمنت اضافيه انت بتضيفها للمصنع على اساس انك انت تحسن في شنو؟ في الكواليتي. فازال كانت انها هي تشتغل على اساس انها تنتج اصناف بهاي كواليتي، وفي نفس الوقت الاصناف تكون يونيك وبافوردبل برايس. دي كان الجول بتاعنا الاساسي. طيب في 2017 كان اللانشنج للاين كامل هو النيتروسيتيكالز، واصعب جزء في المانيفاكتشرنج هو النيتروسيتيكال، لانك انت كبسوله واحده المفروض تضيف فيها قريبه ل 29 او 30 اليمنتس مع بعض. فهو كان تحدي للشركه انها هي تقدر تنتج نيتروسيتيكال هنا في السودان. فالحمد لله احنا قدرنا على الحاجه دي وبدينا طوال ان شاء الله في اللاين بتاع النيتروسيتيكالز. في 2019 شركه ازال حازت على شهاده الايزو سيرتيفيكيت في الكواليتي مانجمنت سيستم. في 2022 ازال عندها مور ذان 80 برودكت هو افيلبل في الماركت، والماركتنج ديبارتمنت اكثر من 90 ممبر شغالين في الجزء بتاع التسويق. باختصار هتكلم لكم عن البورتفوليو بتاع ازال. في اصناف انتم بتكون مرت عليكم وكتبتوها او البيشنت جاكم بها، وفي اصناف ممكن تكون جديده. طيب عندنا الانتي افكتيف هو لاين. الاول هو الكلاديسينومايسين بالدو سترينجز ال 250 وال 500 ملي جرام. بعده الدنتكير والسيناجين والفيرميزان. الدنتكير هو مولكيول لناس الدنتال، هو جديد، عباره عن كومباينيشن بين السبايرامايسين والمترونيدازول بلوكال سنتيليشن من المترونيدازول ولوكال سنتيليشن من السبايرامايسين، على سمهم الاثنين مع بعض يدينا سينرجيز افكت. وهو سبيتر زان الاموكسيسيلين والمترونيدازول اللون ان كومباينيشن الاثنين مع بعض. السيناجين هو اللاين او الممبر اللي بعد المترونيدازول. هو سينيدازول جاي از 4 تاك مع بعض از سنجل دوز، وهو جنريشن بعد المترونيدازول. برضه عندنا شنو؟ الفيرميزان هو فيرمينازول. طيب عندنا الازيثرومايسين بالدو سترينجز 250 و 500. طيب برضه عندنا الكوينونز، الاوفلوكساسين، الاوفلوتاب، والنوروزال هو النورفلوكساسين، والسيبروزال هو سيبروفلوكساسين 500 ملي جرام وسيبروفلوكساسين 750 ملي جرام. والسيبروزال 750 هو اول برودكت هي بدات به الشركه، وده كان التوجه بتاعها انها هي تنتج اصناف تكون يونيك، في انه الماركت كله كان ماشي على 500، لكن في ازال كان بدينا بشنو؟ بال 750 ملي جرام. طيب برضه في سكسس ستوري هنا في الموضوع بتاع الانتيكافير اللي هو الهيباكيور. الهيباكيور جاء من ريكومنديشن بتاعت الجمعيه بتاعت الجاسترونترولوجيست انه هم محتاجين لانتيكافير يكون هو متوفر في السودان وبسعر يكون شنو؟ مناسب. فازال طوالي لبت النداء وبدت في شنو؟ في الريجستريشن بتاع الهيباكيور انتيكافير 0.51 ملي جرام. اول انتيكافير هو موجود هنا في السودان with affordable price، والحمد لله يسعى مدينا ريزلت بالفايرال لود والبروجنوزز عموما في الناس اللي عندهم هيباتايتس بي. برضه عندنا الزافرال هو الاي سايكلوفير بين التو سترينجز بتاعته. مشينا ثاني لللاين بتاع الكارديو فاسكولار. اول برضه عندنا هو الاملوزال، الاملوديبين 5 و10 ملي جرام بعد الاتينوزال. وعندنا الازاتون، الازاتون ده هو الاسبايرونولاكتون، وهو نزل ب2 سترينجز لانه محتاجين مرات لل50 اللي هي الدوز الاعلى. ففي ازال عندنا الازاتون 50 ملي جرام، وبرضه عندنا الازاتون 25 ملي جرام اسبايرونولاكتون من ازال. برضه عندنا الكوزال وده هو فيرست بدينا في شنو؟ از اي ار بيز. كوزال 25 و500 اللي هو لوزرتان. طيب عندنا برضه من الادويه القديمه هو الازابريل جايب الفور سترينجز بتاعته 2.5 و5 و10 و20. لاستلي برضه ازال سماعات الكانديزال 8 ملي جرام از كانديزالتان 16 ملي جرام و32 ملي جرام. وناول شغالين في شنو؟ في الكومباينيشن كانديزالتان معاه هيدروكلوروسيازات اللي هو الكانديزال بلس. طيب عندنا البيزوبرولول اللي هو البيزول 2.5 و5 و10. برضه عندنا التلميزاتان اللي هو التلميزان بالسترينجز بتاعته ال 20 وال 80 وال 40 ملي جرام. زي ما عارفين هو لونج ديوريشن اي ار بيز. طيب برضه عندنا الاتورفازال ال 20 وال 40 ملي جرام. ولاستلي هذا برضه صنعت الريزوفا ستاتين مع الجايد لاين. زي ما بروف انه الجايد لاين مشى لانه محتاجين لي هاي انتنسيتي لورين في شنو؟ في الكوليسترول والال دي انه الجول بقى اقل من 50 او 70 في الناس اللي عندهم مشاكل بتاعت الفيري هاي ريسك. فازال برضه وفرت الريزوفا ستاتين اللي هو هاي انتنسيتي ستاتين وبكونسنتريشن 40 ملي جرام، ممكن موجود في السوق ال 20 وال10. فازال برضه وفرت ال 40 ملي جرام على انه مرات بنكون محتاجين ان نستخدم هاي انتنسيتي من شنو؟ او هاي دوز من الريزوفا ستاتين. برضه عندنا الازافورمين هو الميتفورمين 500 و850. وعندنا الجليميزال اللي هو جليميبرايد 2 و3 و4 ملي جرام. برضه عندنا اليوريجينيزال الجولدن تاب هو للريتايل ديسفنكشن، والجوي تاب للبريماتيور ايجاكيوليشن. عندنا البروساسيف هو فينسترايد، والكارديوسين اللي هو دوكسازوسين بكل السترينجز بتاعته. دي اتكلمت عنها قبل اللي هو النيتروسيتيكالز. عندنا ازاكال هو كالسيوم بيور. عندنا الفيتازال هو مالتي فيتامين اوتونيك. وعندنا برضه الهيمازال هو هيماتونيك فورميلا. وعندنا البريجنال هو بريجنانسي فورميلا. طيب اضافه لكده عندنا الستريزال هو فيتامين سي. وعندنا السكرازال هو سويتنر. والنيوروزال تراي بي 1 وبي 6 وبي 12. وبرضه عندنا الاوستيوزال وهو الكالسيوم مع فيتامين دي ومغنيسيوم وزنك. طيب عندنا الانالجيزيك برضه في ازال اللي هو موبيزال 7.515. ديكلوزال دايكلوفناك صوديوم ودايكلوفناك بوتاسيوم الفنام كي وزدوريك استرا واميفنيميك اسيد. واخر حاجه برضه عندنا البروفيزال هو الكيتو بروفين از هو باعتباره شنو؟ نون ستيرويد الانتي انفلاماتوري دراج. والليبوهيست هو الليبوسيتريزين. برضه عندنا شنو؟ لاين للجاسترونترولوجيكال اللي هو الاسوميزال اسومبرازول والفوميزال، واللانسوبرازول اللانسوفاس، والاوميزال هو اوميبرازول. وازال عندها يعني الرؤيه بتاعتها ان اي سجيشن لبرودكت معين هو عنده نيد حقيقيه في الماركت او نيد حقيقيه بالنسبه للبيشنت، ازال ما عندها مشكله ان هي تصنعه. واخر حاجه عندنا هو الدواء هسه حاليا ورقه جاهز في المجلس على سنه نعمل له ريجستريشن، وهو حينزل بسعر مناسب جدا ويكون افيلبل وافوردبل للبيشنت. فنحن بنقبل اقتراحاتكم ان شاء الله، وتواصلنا برضه مع البروفيسور انه اي ريكومنديشن من الجمعيه ويلكم في اي وقت ان شاء الله. شكرا جزيلا واسف على الاطاله ان شاء الله.
شكرا جزيلا دكتور عصام، شكرا فور يور سبونسرشيب از ويل. طبعا الموسم ده موسم المؤتمرات وفي دكتور احمد
بعدين اختلفنا عليهم
just 1 minute talk about Sudanese Society of Hypertension برضه عندهم مؤتمر.
طبعا حقنا ب 11 في كورنثيا Sudan Hypertension Society meeting, one day event launching a hypertension guidelines. So if you want to know about Sudan hypertension guidelines, very evidence-based, very updated. Professor Bahir معانا في executive committee, مش executive committee في scientific committee, he's heading it actually تقريبا. You want to know عندنا guest speakers, عندنا guest speaker from the International Society of Hypertension, Professor Groff from Italy, وعندنا regional speaker. We're also launching the only investigator project عندنا for you those who are interested, and presenting our local data M&M project 16,000 reading من السودان. So it will be exciting. في معارض كويسة و there will be good food. دفعنا مش كويسة.
يا سلام.
Yes. Thank you very much.
Right, thank you. شكرا جزيلا دكتور أحمد. I think now we come to the close, and at the end I'd like to thank all the speakers. I think we have a very good day. We have a cocktail of scientific presentation, which are up to date and very sophisticated presentation from all the speakers. Thank you very much. And as you know, we are in the Department of Medicine, Faculty of Medicine, University of Khartoum. We are dedicated for continuous education, and we will continue. We will strive, and we'll continue to feed you with all scientific material. We will stop for 4 weeks because of the exams, and we resume and we'll give you a notice, and I think we will have also a very important meeting after the exam. Dr. Rashid, Professor Rashid.
أنا عندي بس وصية دار أقولها. أول حاجة يعني thanks very much for Professor Bagar for bringing this innovative idea of update symposium. We applaud him for not only this, because he has been doing a lot and great work for us for generations, not today يعني from the time we first met him when he was much younger, and still he's very young in the heart and the body. We have to applaud أول حاجة Professor Bagar for the effort. My second suggestion is to make this meeting more attractive is to reduce the number of the talks of updates, because دائما احنا عندنا تكنولوجيا ومشاكل كده. دائما افتكر the number of speakers will be around 3 as at most to be more attractive. Third, to attract more physicians, نحاول نكتب للمجلس الطبي نخلي الميتنج بتاعنا عنده CME points، لانه CME points في الاجتماعات اتاكس الدكاتره، لانه حتى الريجستريشن والمينتنس بتاعه حتى بالنسبه لكم لازم تجيبوا 10 CME points عشان احنا نبقى فوكس للدكاتره يجونا نعمل نكتب للمجلس الطبي. افتكر بروفيسور مصباح يراد للمجلس الطبي انه يدونا مثلا الميتنج بتاعنا الساعه حاجه مثلا 6 credit hours ولا وات ايفر، على اساس انه احنا وي اتراكت more and more people to come and learn، لانه ده يبقى تشينج بوينت للعلم هنا. وشكرا جزيلا.
The son is the chairman of the Department of Medicine.
As you know. السلام عليكم يا شباب، ثاني وثالث ما دارين نكتر عليكم. Thank you for coming. حسب اتكلم مع بروف عمر زايد قلت له لو جونا ريجسترارز يعني بفتكر يعني نعمل more publications يعني او نعمل announcement للميتينج. بفتكر it is good انك to come to learn to listen، مش كده اسهل حاجه انك you listen والله. بعدينك اشكر تاني بروف الباقر وبعديك الريكومنديشنز اللي قالوا او شيخ والله we took it on board already يعني عشان نقدر نلقى ال CPD points. انتوا عارفين if you did go to anywhere in the world دائما يقول لك what are during this year how many CPD points you have collected. Thank you for coming يا اخواننا تاني وتعال.
شكرا لكم. Enjoy your refreshment.